Okay. Got it. You're here. You're on the panelist now. Okay.
Hi, hello. Welcome, everyone. Thank you for joining us today. Hello. Hello, Sharonda. Thank you for joining us. Thank you. Thank you, everyone. Yes, we'll be sharing the information about how you get CMEs during the webinar shortly. If you give us a few minutes, we'll be sharing that information. Thank you so much.
And we're officially live on YouTube.
Amazing. Thank you. Let's give everyone about maybe 2 more minutes to join us, and then we'll get started. We are so excited to see everyone. Thank you so much for joining us today. Welcome, welcome. Thank you. Welcome. Thank you for joining us today. Good morning. We'll be starting in a minute. We'll be sharing our slides and starting off and kicking off the 8th annual Chicago Sickle Cell Summit in a minute. Amazing. Thank you so much for joining us. Good morning, everyone. We all know September is National Sickle Cell Awareness Month. Happy National Sickle Cell Awareness Month. Next slide. Good morning once more, and welcome to the 8th Annual Chicago Sickle Cell Summit. I am Beverly Chukwudozie, and I am honored to be one of the hosts of today's summit. This year's theme is Double Whammy, Managing Comorbidities with Sickle Cell Disease. This reflects our shared commitment to exploring the unique challenges of sickle cell care when other health conditions are present. Now, we're delighted that so many of you, warriors, caregivers, clinicians, advocates, researchers, and community partners are joining us virtually from across Chicago and beyond to learn, share, and inspire action for persons living with sickle cell disease. Now, this summit cannot be possible without the generosity and visions of our partners and our supporters. And we give a heartfelt thank you to all the health systems mentioned here in the logos below and the community-based organization and each of our warriors and family advocates who your commitment drive the progress we celebrate today. Next slide. So our disclaimer is all information shared today is intended for educational purposes only and is not a substitute for professional medical advice or diagnosis or treatment. Please consult your own qualified healthcare provider for any personal health concerns. This summit also is recorded, and by attending, you are consenting to use your voice, your image, without time limit or compensation. We also strive to maintain a safe and respectful virtual environment. Please ensure that your engagement and communications maintain these standards. Next slide, please. So these are so many some ways that we would like you to make this a truly interactive event while respecting everyone's privacy. You can join the conversation using the summit hashtag, which is hashtag Chicago SCD Summit. Hashtag Chicago SCD Summit. Use it on all social medias to tag us, and so we can all see the great information that everyone is getting from the summit. You could also, to protect your identity, everyone except presenters will remain in listening mode throughout the sessions. And so ways that you can engage is using the chat box to share comments and helpful resources with fellow attendees. For questions to the speakers, please submit it through the Q&A panel at the bottom. And you can also complete the evaluation form when you exit out of Zoom. Next slide, please. So we do have continuing education credits. This is available for eligible participants. And to get this credit, you have to sign in with the email you used in registering for the summit, attend the summit, and when you ensure that you exit out, so log out of Zoom. And once you exit out of Zoom, you will get an exit survey that you can complete and choose the credits that you're interested in. And so also you will get an evaluation via email. Please complete that by October 15th to get those credits. If you do have any issues with getting, the exit or the evaluation, please email Dr. Norsek. Judy Norsek's email is jnoCek@uic.edu, and her email is at the bottom of the screen as well. Next slide. All speakers and planners have disclosed any relevant financial relationships, and any potential conflicts of interest have been reviewed and mitigated. And they are all listed here on this slide. And we can make that available if anyone really needs it. Thank you. Next slide. And here's a brief look at our schedule. We have 4 interactive and informative sessions, and we hope to end the summit at 3 p.m. And without much ado, I would like to introduce a speaker who is going to give the summit dedication. I would like to introduce Dr. Victor Gurduk. Dr. Gurduk is a professor of medicine at the Department of Medicine, Division of Hematology and Oncology at the University of Illinois College of Medicine, Chicago. Welcome, Dr. Gurduk. Hello, Dr. Gurduk.
You're
Oh,
muted.
Oh, do you hear me now?
Yes.
Okay, yeah. Thank you. Thank you. It's really nice to be here, and it's nice to remember Dorinda at this summit. And as we gather for this 8th annual Sickle Cell Summit, we want to remember and pay special tribute to Dorinda Lawrence Sims, who went to be with the Lord on May 21st, just 4 months ago. Dorinda helped plan, shape, and uplift this Sickle Cell Summit year after year. And in fact, she played an important role in planning this very summit in which we are participating today. Dorinda Lawrence Sims was the founder and executive director of the Circle of Life Center for Hope Sickle Cell Foundation. She was a brilliant professional, a certified public accountant with a bachelor's degree in business management and a master's degree in accounting. Dorinda brought excellence to every role she held, including her time as board treasurer for sickle cells. Since 2016, she faithfully served as a community advisory board member for the NIH-funded Sickle Cell Disease Implementation Consortium, specifically our Isaac project here in Chicago, which aimed at improving care for adolescents and adults with sickle cell disease. Dorinda made sure the patient's voice was not just present, but heard, respected, and publicized, and prioritized. Her collaborative work with organizations like the Sickle Cell Disease Association of America, the Sickle Cell Disease Association of Illinois, and many other organizations speak to her incredible ability to build bridges, to unite efforts, and to get things done. Though Dorinda is no longer with us physically, her presence is deeply felt. Dorinda leaves behind a legacy of strength, compassion, and progress that we are honored to carry forward. She was a masterful listener. She made sure she understood the complexities of a situation before she offered her opinion. Dorinda was a strong leader, but she was also humble and meek. And as Jesus said, "Blessed are the meek, for they shall inherit the earth." We are so grateful to Dorinda Lawrence Sims for everything she did. We miss her, we honor her, and we commit to keep doing the work with the same fire, grace, and commitment that she demonstrated. Really wonderful, wonderful, wonderful colleague, Dorinda. Turn it back over to you, Beverly.
Thank you so much, Dr. Gaduk. We really appreciate that warm, heartfelt dedication to a friend and a colleague, and always keeping us on our toes and making sure that we're accountable. Thank you. Next, I'm going to invite Dr. Santos Saraf to give the welcome remarks and also introduce our keynote speaker. Dr. Santos Saraf is the Associate Professor of Medicine in the Division of Hematology and Oncology at the University of Illinois College of Medicine, Chicago. Dr. Saraf is also the Director of the Adult Sickle Cell Program at the University of Illinois Hospital and Health Science System. Dr. Saraf, thank you.
Thank you, Beverly. And it's an honor to give the welcome remarks on behalf of the University of Illinois Chicago, but really also highlighting that this is a partnership with other healthcare organizations, community organizations, and most importantly, the patients. So I think that this program is really dedicated and focused for our sickle cell warriors. And just a little bit of history, but sickle cell disease was actually first described here in the Western literature in Chicago. So Chicago really has a long legacy and history of caring for sickle cell disease. We have been at the forefront of a lot of the research understanding the pathophysiology of sickle cell disease, as well as in developing therapies, including things like hydroxyurea and some of the newer therapies. And it really is an exciting time as there are more therapies that are on the horizon, including gene therapy, and as we better understand some of the complications. This symposium is really going to provide a nice overview of some of those complications, including some of the chronic organ disease problems. But I'm really excited to also be able to integrate the neuropsychology component. And with that, I'd like to introduce Dr. Kyle Jeanette, who's going to be our keynote speaker. So Dr. Jeanette is a clinical neuropsychologist and assistant professor of clinical psychiatry, neurology, and transplant surgery at the University of Illinois, Chicago. He earned his bachelor's degree in psychology from Flagler College, a master's degree in gerontology from the University of South Florida, and a PhD in clinical psychology with emphasis in neuropsychology from the University of Wisconsin-Milwaukee. He completed his clinical psychology internship at the University of Chicago Medical Center and a fellowship in clinical neuropsychology here at the University of Illinois, Chicago. Dr. Jeanette's clinical and research expertise is focused on neuropsychological functioning of adults with chronic illness and complex psychosocial needs. He is passionate about improving access to neuropsychological services and brain health resources for traditionally underserved populations. He has created and coordinated multiple specialty, interdisciplinary, and embedded clinics, including embedded neuropsychology services in sickle cell disease, transplant surgery, emergency medicine, neurology, long COVID, and memory disorders. A large area of his research focuses on understanding the intersection of cognitive functioning and social determinants of health to improve access to care and outcomes in patients with complex medical and psychosocial comorbidities. On a personal note, I've been very, very happy to be able to collaborate with Dr. Jeanette. He's worked closely with our Sickle Cell Center for the past year and a half, and it's clear he has a really strong passion in what he has developed his clinical and research expertise, including the neuropsychological functioning in sickle cell disease. So with that, I'd like to introduce Dr. Jeanette, and the floor is yours.
Thank you so much, Dr. Saraf, for that very kind introduction. And I'm very, very happy to be here and present with you all. I'm just going to share my slides, do all the standard check-ins that we can see things. All right. Okay. I think. Oh, sorry. There we go. Okay. Should just be seeing my presented slide now. Okay, so again, good morning. And again, thank you, Dr. Saraf and everyone else for being here and welcoming me as the keynote speaker to discuss psychological well-being and mental health in sickle cell disease. This is a huge topic to cover in 30 minutes, and I'm notorious for going over on time, so I'm going to try and be really succinct. But my goal today is to share some of the general information that we know about psychological functioning and well-being in folks with sickle cell disease, some of the factors that contribute to mental health and psychological well-being, and some of the things we can do to improve overall well-being, but especially psychological health in our patients. I don't really have any disclosures except to say that my work in the sickle cell clinic is supported by a grant through the Illinois Department of Public Health. Okay, so as I said, my priority today is to go over the broad concepts related to chronic illness and especially sickle cell disease in psychological well-being, and understand this concept of the biopsychosocial perspective of health and psychological well-being. I want to talk about the unique characteristics of sickle cell disease as a chronic illness and the psychological factors that contribute to well-being, and then talk about some of the broad interventions and strategies that we can employ to improve care for individuals with sickle cell disease. Okay, so let's start big picture. Let's start by talking about psychological well-being and chronic illness on the whole. So first, some definitions. So chronic illness is defined as any condition that lasts for more than a year, impedes daily function and abilities, and requires consistent and constant medical treatment. Living with any type of chronic illness, be that sickle cell disease, diabetes, anything of the like, increases your risk of psychological distress and mental health related problems. Such that, based on some work by the NIH and the CDC, the probability of being diagnosed with a depressive disorder is 1.7 to 3 times higher in patients with chronic illnesses compared to those that do not have chronic illnesses. And approximately 40 to 60% on the conservative end of individuals with a chronic illness will be diagnosed with depression or anxiety during their life. So it goes without saying, and it's pretty easy to understand that depression is going to impact the severity and the progression of chronic illness. Patients that have chronic illnesses and have depressive disorders consistently report more significant and more frequent medical symptoms compared to patients that just have chronic illnesses alone without depression. These can be things like increased pain, more frequent pain, increased fatigue, more severe fatigue, neurologic and cognitive concerns, among many, many other concerns. So it creates this cycle of having a chronic illness can be exacerbated by psychological distress, especially depression, and that depression can be worsened by illness. And then it leads into this feedback loop of chronic illness being worsened by psychological distress. And a common concern and factor here for folks with chronic illnesses that develop psychological distress is that a common symptom of depression broadly is reduced self-care. And effectively managing a chronic illness requires consistent self-care and monitoring, such that when depressive symptoms get worse, there's higher disability and increased risk for mortality if those depressive, anxious, or stress-related symptoms are not effectively treated. And if we look at what the core symptoms of depression are, we can see that many of these symptoms do have crossover with a lot of the complaints that individuals with chronic illnesses face. Things like changes in appetite and weight, sleep problems, psychomotor slowing or feeling agitated or restless, loss of energy, increased fatigue. And then, of course, relevant to self-care, anhedonia, which is this marked disinterest or lack of pleasure from things that you typically engage in, or a lack of ability to engage in things that you need to. So you can imagine when folks are already dealing with these symptoms as a consequence of a chronic illness, and then depressive symptoms exacerbate these problems and make them worse and more impairing, this can lead to more problems that can worsen chronic illness and increase risk for more problems. So beyond just the individual level psychological distress that people can experience when they have chronic illness, people can experience psychosocial disparities in chronic illness that exacerbate both the physical symptoms of their illness and the psychological symptoms that may develop. And when we conceptualize this, we can think of this falling into two broad buckets of psychosocial disparities and factors that can contribute to reduced engagement in care or reduced health outcomes. One of these is called social drivers of health or social determinants of health. And these are community level disparities that people experience and that people with chronic illnesses experience at much higher rates. Things like problems with economic and financial stability, access to education and quality education, access to healthcare and specialized care, the neighborhoods that they live in and the built environments that they exist in, access to infrastructure that supports their ability to receive services and access resources, and their social and community context and the ability for them to connect with other people. And this is complemented by health-related social needs, which are more at the individual level and can result in disparities. So individual level problems with financial stability, such as occupational stability, ability to work a full-time job that covers your rent and covers your expenses, lack of access to essential resources like healthy food, affordable and stable housing, access to healthcare within your community without having to commute or travel multiple long distances or requiring lots of complicated public transportation. And then access to transportation, being able to own a car, being able to pay for public transportation, being able to have access to ride shares and taxis. These are all factors that could further exacerbate psychological distress and worsen engagement in chronic illness management. So practically, as I already noted, this can result in problems that we need to be aware of as providers and how we're going to support our patients that may have these barriers despite all of their best intentions to be fully engaged in their care. How far are they from our clinic? How aware are they of the services that are accessible in the clinic? Do they even have access to referrals for specialized care? Do they have the infrastructure to be able to get to us? And do they trust our health system? Can they take time off of work? Do they have access to childcare or elder care if they're a sandwich generation that's caring for both parents and children? What are the barriers of their insurance? What will it cover? What will it cost them? And what are the levels of their health literacy, their cognitive and psychological functioning? Chronic illnesses often come with other concerns like problems with cognition that can be a barrier to their ability to engage in care. And these are factors that we need to always consider beyond just psychological functioning. We also need to consider the lived context that our individuals are coming from. So what drives these psychosocial disparities? I'm a big fan of maps. This is one of my favorite maps in the research I do. This is from something called the Neighborhood Atlas developed by the University of Wisconsin at Madison, where they were able to categorize communities at the block level down to the street level and their level of access to resources relevant to their well-being and their health care. Things like income, safety of neighborhoods, things like that. And in this heat map, darker red colors, oranges, yellows represent higher resource deprivation, meaning reduced ability to access necessary resources. Whereas your blues are going to represent communities that have ease of access and have high resource availability. So I think you see where this is going. Barriers to resource and care are not just at the individual level, they're at the community level. So these resource disparities that have nothing to do with the individual themselves, but the lived context that they're in, can impact their ability to manage their chronic illness, increase their risk of psychological distress, and increase problems with their general health care. And we know that neighborhood disadvantage has consistently been linked to poor health outcomes and reduced access to care. Individuals that live in these communities with higher ADI, meaning area deprivation index, more disadvantage, have higher rates of cardiovascular disease, higher rates of psychiatric diagnoses, higher rates of neurocognitive disorders. They even have higher rates of Alzheimer's pathology when all other things are equal. They have higher rates of death from all causes of illness, among many, many other studies that have been done using these data. And we are a good petri dish here in Chicago for this broader problem of access to behavioral health and mental health services. So communities with higher health disparities have lower access to mental health care. So this was a study done by the Chicago Alliance for Mental Health, looking at access to behavioral health providers in Illinois and the Chicagoland area more broadly. So if we zoom in on Chicago specifically, we can see that for every 10,000 residents in these blue areas, there are upwards of 121 behavioral health providers, be that psychologists, psychiatrists, social workers, mental health therapists, patient care advocates. Whereas in the communities with higher ADI, predominantly on the south and west sides of our city, there are fewer than 30 per 10,000 providers available. There's nearly 5 times as many providers in these high resource communities relative to the low resource communities. This further propagates problems of psychological distress and access to care to treat these problems. So let's integrate this all together. So this is where I'm introducing this concept of the biopsychosocial model, which is kind of the unifying theme of this whole talk. We know that people with chronic illness have significant biological factors that contribute to their well-being. There's things we can control and there's things we can't. Like our genetics, we can't control. We can have some degree of control over our physical health, the medications we take, the treatment we receive. But when we have chronic illnesses, we're on medications that may cause secondary effects on our well-being, and we have chronic hospitalizations, like in the case of sickle cell disease, that's going to decrease our quality of life. And these problems are going to overlap with other psychological factors, like baseline personality and coping skills, sense of self-esteem and efficacy, and disorders like depression, anxiety, stress, trauma, and the degree to which people have a sense of resiliency in the face of adversity. Then finally, these things overlap with those psychosocial and social determinants of health factors that I mentioned. Financial stability, occupational stability, reliable relationships, family and social connections, supportive housing, community, etc. And all of these things intersect together to predict degrees of well-being, quality of life, and functional independence. So some of these things don't fit neatly into one bucket, and they're the intersection of two things. So for example, cognitive functioning, higher psychological distress, higher biological or medical problems, more issues with cognition, issues with sleep, worsening pain symptoms. The inability to access care can create social isolation. We will withdraw from family and friends. We will withdraw from our communities if we're feeling sicker and unable to engage. And all of these things are concomitant upon each other to predict the degree to which somebody has a sense of well-being. Now, this isn't all doom and gloom. So while these factors increase the risk of lower quality of life, this also introduces multiple different targets for intervention to improve overall functioning and quality of life in people with chronic illnesses. All right. So let's zoom in now a little more specifically on sickle cell disease. So some statistics. So the statistics on sickle cell disease and psychological functioning are a bit complicated because they're hard data to collect, and there haven't been too many large sweeping studies of overall psychological functioning in sickle cell disease. That said, if you look at some of the meta-analyses that combine lots and lots of studies together, the prevalence of depressive disorders in people with sickle cell disease is anywhere between a quarter to more than a half of individuals with sickle cell. The most common symptoms reported are feelings of social isolation, irritability and agitation, feelings of helplessness, low mood, fatigue, appetite problems, sleep dysfunction, and increased probability of suicidal thoughts and feelings. Anxiety, on the other hand, has a lower prevalence rate, but is still certainly higher than the average in people with other chronic illnesses and the baseline of the community without illness, and it ranges anywhere from 6 to 29%. And we know that the presence of depression and anxiety or symptoms of depression and anxiety are often better indicators and better predictors of symptom severity than other biological markers, like in sickle cell, like hemoglobin levels. And this is true across all chronic illnesses. So living with sickle cell disease, if it wasn't apparent, increases challenges and mental health barriers and reduces quality of life. And people with sickle cell disease manage multiple cognitive, emotional, and psychosocial challenges. The depression, anxiety, and stress we talked about, the sleep dysfunction and social isolation, the inability to engage fully with work and school and recreational activities that give a sense of agency and autonomy, and the psychological effects of pain and uncertainty about illness and progression of disease, and the higher rates of cognitive impairment and deficits that can occur. So all that to say, there are broad and substantial impacts on quality of life, and that's what patients with sickle cell are telling us. So the largest survey to date that has evaluated quality of life in people with sickle cell disease was the Sickle Cell World Assessment Survey done in 2021. It's called the SWAY study, and it assessed a little over 2,000 people across 16 countries on various quality of life measures in sickle cell disease. All of the questions in the surveys were on a 1 to 7 scale, where 1 was basically the absence of a problem or severity of that problem or something that wasn't really impacting life, towards 7, which is a substantial impact or worst imaginable symptoms that someone could experience. And what the researchers did is they took responses of 5, 6, and 7 on that high end and categorized that as high impact and severity, and rated what are the biggest issues that people with sickle cell disease are reporting across the world. And here are some of those data. So these data represent the percentage of people that rated 5, 6, or 7 on the various scales. And for this, we can see that, of course, sickle cell has a substantial impact on daily life activities, where that more than half or close to half of individuals with sickle cell disease report avoidance of physical activity, worry about pain when engaging in physical activity or exercise, worry about exhaustion, worry about dehydration. And that's 50% or more. But we can still see on the other side of this graph that there's a substantial proportion of individuals that have daily life activities impacted by the uncertainty and the severity of their disease. In terms of specific items, these were the highest rated items that were 5, 6, or 7 with the highest frequency of endorsement. 60% of individuals with sickle cell disease report that their emotional well-being has been impacted by their disease, that they feel frustrated, that they feel worried, that they feel like they are a burden to their family and that other people have to take care of them. Stress, fear of dying. All of these problems are persistent and present more often than not in people with sickle cell disease. So all that to say, about 40%, again, with the statistics being a bit unclear, of people with sickle cell disease worldwide report having been diagnosed with depression or anxiety. And when you break that down by regions of the world based on income, it's up to 50% in high-income countries. People with sickle cell that have been diagnosed with depression have a 3 times higher rate of healthcare utilization, higher rates of presenting to the emergency room, higher rates of attending or needing more doctor's appointments and care. And 60% of people with sickle cell disease have, or excuse me, they have a 60% higher frequency of hospitalizations and ED presentations. And this is just as a factor of being diagnosed with depression. So it's clear that psychological distress is associated with more frequent, intense, and longer lasting pain crises. And then even when people are not in an acute pain crisis, depressed patients with sickle cell disease still have a higher baseline reported pain severity and higher reported disability due to their pain. So despite this, from the SWAY study, 64% of people in the survey, of those 2,100 people, reported not having access to professional emotional support like psychologists, therapists, and psychiatrists. And that's despite roughly the same number of people desiring access and care for their mental and behavioral health. And these things have a trickle-down effect, of course, on the ability to engage in meaningful employment and school, such that the majority of individuals report problems with access to work, promotion, ability to sustain employment, ability to sustain engagement in school. And this just reinforces that point, that school was more difficult, less interesting, harder to perform in, harder to keep up with, and less fulfilling. So what we have here is a vicious cycle. So the impact of sickle cell disease on academic and occupational functioning and daily functioning increases financial burden and stress. And this further increases and leads to a higher probability of depression and anxiety, which can lead to worsening symptoms and reduced disease management. All right. So we also have to consider the unique factors of sickle cell disease and some of the stigma that's associated with the disease. So individuals with chronic illnesses overall, especially invisible illnesses where there's not a very obvious problem or illness, have higher rates of stigmatization, higher rates of misunderstanding from the lay community of their illness, or even from the medical community, and a minimization of their lived experiences and the impact of their symptoms on their functioning. There are unique stigmatizing challenges for folks with sickle cell disease, such that there's higher racial disparities in this disease. 90% of people with sickle cell disease identify as Black, and 9% identify as Hispanic or Latinx. And there are significant racial disparities and biases in the healthcare system and community that limit access and increase stigmatization of the disease. There's also a stigma of people with sickle cell disease being quote unquote drug seeking because they are indeed experiencing significant pain related problems and they do need high dose and high demand pain management to treat their disease effectively. And then in general, there are just misconceptions about what sickle cell disease even is and what the effects are on somebody's day-to-day life and how it does diffusely impact all spheres of functioning. So we know that people with sickle cell disease endure a lot of discriminatory treatment in medical settings. There have been many studies that have shown racial biases in healthcare, such as false beliefs of higher pain tolerance in Black patients relative to white patients. There have been large-scale studies that have shown that Black and Hispanic patients are less likely to be prescribed opioids at the doses that are necessary compared to non-Hispanic white patients. And we know that race-based discrimination has been associated with more severe pain crises and more severe depressive symptoms in patients with sickle cell disease. So overall, we know that these problems lead to higher rates of financial insecurity, inability to maintain employment or loss of employment, and expensive medical care, such that more than half of individuals with sickle cell disease get their insurance through Medicaid. And that people with sickle cell disease on average spend double the amount of money on their care than patients that are just on Medicaid alone without sickle cell disease. So this further limits the ability to engage and access resources for specialized care and for providers to be able to provide care for patients with Medicaid and offer sustainable services. Okay. So just to round it back out to our original discussion about social determinants of health and health-related social needs, individuals with sickle cell disease are disproportionately impacted by these factors. And this is something we always need to keep in mind when caring for patients with sickle cell disease. Okay. All right. And finally, the unique stressors and risks that are associated with having sickle cell disease and its impact on your psychological well-being. So as I've made clear, people with sickle cell disease are exposed to multiple compounding stressors that can increase the frequency and severity of distress. More specifically, they're under chronic exposure to uncertainty and lack of control. Uncertainty about disease course, inability to control disease course, complications of the disease and what may come up, the onset and impact of disease symptoms and when things may flare up or be exacerbated. And this is the classic model in psychology of high uncertainty, low sense of control equals anxious distress. So with all of that uncertainty and lack of control, it's no wonder that individuals with sickle cell disease experience higher rates of anxiety and stress and higher rates of trauma. There's a lot of trauma exposure related to hospitalizations, significant frequent hospitalizations, treatment complications, and severe pain crises. Okay. I think I made this point clear, but clearly when these psychological stressors impact physical functioning, our nervous system responds to that. Our autonomic nervous system, which is the part of our body that's the fight or flight response, the thing that helps us get ready, get charged up to face a threat, is dysregulated with all of this excessive physiological arousal from pain, from medical complications, and stress and anxiety. And that burns out our central nervous system and can lead to more problems in the long term. And these effects, of course, trickle back down to the community that the individual lives in, the family, and quality of life, and impacts their overall social, emotional, and physical well-being. So it all comes back to the biopsychosocial model and remembering that all of these things intersect together to predict well-being and quality of life, and that we have many targets we have to improve functioning and quality of life for patients with chronic illnesses and sickle cell disease. All right. I know that was a lot of heavy information. Let's talk about what we can do and what we know works. The key when it comes to psychological and psychosocial well-being in any condition is to build resiliency. And resiliency is the process of adapting well in the face of adversity, trauma, or substantial sources of stress. Higher resiliency is associated with decreased emotional distress and perceived stress and better physical and mental health in people with chronic illnesses and people without chronic illnesses across the board. That's our goal in psychology, is to build adaptation and resiliency. So how do we do that? Well, we start targeting all those pretty circles from earlier. We start by targeting psychological well-being with empirically supported interventions. These are things like psychological skill training to improve coping skills and improve skills with managing and coping with pain and fatigue through things like cognitive behavioral therapy. Cognitive behavioral therapy is an intervention technique where you look at maladaptive thoughts and behaviors that increase physical distress and psychological distress and find ways to intervene on those maladaptive thoughts to improve resiliency and coping. In that same vein, we can use cognitive restructuring and psychoeducation to address misconceptions and stigma that individuals experience in their community and improve communications with providers and their community. Understanding how to increase self-advocacy and communication with people that may not understand their disease and the effect it has on them. Having a greater sense of self-advocacy increases agency and sense of control, and that improves overall quality of life and psychological well-being. And finally, things like behavioral activation. Fatigue and pain are very limiting in how much you can engage physically, but the extent to which individuals can engage in any degree of values-based activities to improve their quality of life and emotional well-being is a step in the right direction, has been shown to be very effective in improving psychological health. So the overall here, being mindful of my time, is that we need to maximize protective factors like increasing access to psychotherapy interventions, family and caregiver support, and community and religious connections that improve values-based care. We need to address exacerbating factors like being aware of adversity in patients' lives, addressing maladaptive coping strategies and avoidance behaviors that are going to increase psychological distress, and provide resources and check in often on psychological health. More than anything, we always need to be proactive, not reactive. We need to connect individuals with mental health resources and services and make them aware of these services before a problem starts, which can be tricky. We need to monitor all aspects of psychosocial, psychological, and cognitive functioning regularly. And we need to provide psychological support regardless of the severity of the condition or the treatment. It doesn't have to get to the point where it's really bad before someone needs to see a psychologist for some extra support. This should be something that's available to anybody. On the bigger picture, we need to improve our education and awareness of sickle cell disease through amazing programs like Sickle Cell Summit, but also in the popular media and social media. I think a great example of this recently was on the second episode of The Pit, where an individual with sickle cell disease was accurately portrayed and the struggles of dealing with being labeled as a drug seeker were addressed. We need to increase this kind of awareness. And we, of course, across all boards, regardless of sickle cell or any other conditions, we need to support access and equity. Dedicated psychologists, social workers, and other mental health providers should be embedded and easily accessible in chronic illness clinics like sickle cell disease, like the work we're doing here at UI Health, where I'm embedded in the service and available for on-the-call neurocognitive consults. We always need to be aware of the lived experience of our patients and recognize the social drivers and health-related social needs. And we need to advocate beyond the clinic. We need to support and prescribe accommodations and modifications at work and at school for our patients that are struggling to maintain employment or engage in school. They are entitled to these accommodations through the Americans with Disabilities Act. And to make any way that life can be easier to function with a chronic illness, we should be doing that. And then finally, ironically, with me being a neuropsychologist, I only have 2 slides dedicated to cognition. We need to constantly screen for cognitive concerns because we know that people with sickle cell disease are at much higher increased risk of neurocognitive impairments due to higher risk of stroke and cerebrovascular disease and other morbidities. And we know this works. So this is work that our group has done previously in the sickle cell clinic, where we know that giving people neuropsych evaluations in clinic both reduces the cost associated with their healthcare, upwards of $1 million in savings annually for the 73 individuals that got a neuropsych evaluation, and it decreases the number of hospitalizations and ED visits by between 40 and 70%. So we know this stuff works and it's actually practical. Okay. So the take-home message. People with sickle cell disease have higher risk of psychological distress. There are systematic and disease-specific factors that present barriers to effective care and psychological well-being. If we're going to provide ethical and effective care for people with sickle cell disease, it's going to require multidisciplinary and collaborative approaches. We can't approach this with traditional strategies. We have to be creative. And it's always crucial to come back to those pretty circles I showed you earlier and understand the intersection of biological, psychological, and psychosocial factors to optimize health and well-being for people with sickle cell disease and frankly for anyone. And with that, I would be very happy to take any questions if the time allows, but otherwise, here's my contact information. Please reach out anytime if I can be helpful. And thank you for your time.
Thank you so much, Dr. Jeanette. Really appreciate the wonderful keynote and presentation. I will ask one question, and I know you kind of gave really, really great tips in your presentations. I heard them, but I really wanted to ask, like, how can we begin to break down the stigma surrounding managing sickle cell disease and mental health and create a supportive and an understanding environment for those affected?
Absolutely. It's a huge problem, right? And it means we have to be advocates in every phase of our life, right? Not just when we're in the clinic, not just when we're going with family members to the hospital. This needs to be something that we're constantly communicating to our colleagues that maybe don't work in sickle cell disease. And we need to be encouraging accurate representation and destigmatization of this disease in popular press. We need to be doing activities like this of presenting to the community and sharing information and understanding with disease. Knowledge is power is the cliche, and that's true. We need to be just pushing more accurate information constantly and correcting stigmatizing thoughts and behaviors.
Thank you so much. And I think that's all the time we have. If there are questions, you can still put them in the Q&A, and if Dr. Jeanette is still available, he will respond. If not, we will share that via email as well. Thank you so much.
Thank you all.
Thank you. And now we will go to our next speaker. This is going into our session 1, and I have the pleasure of introducing Dr. Philip Aldana. Dr. Aldana is a University of Florida professor of neurosurgery and a board-certified pediatric neurosurgeon at the University of Florida Health in Jacksonville. He also serves as the chief of the University of Florida Division of Pediatric Neurosurgery in Jacksonville. Dr. Aldana is coming live from Mongolia. Thank you so much for being here and presenting to us. Thank you.
Well, thank you for that introduction, Beverly, and good morning to you all. Good evening here. It's 11:48 p.m. In Mongolia, but I'm still on Eastern time, so it's not that bad. So I'd like to thank the organizers, especially Dr. Sue, for inviting me to talk about my research and my interest in sickle cell disease, particularly in preventing stroke through surgical revascularization. What you might term in lay words is brain bypass surgery. So I'm going to talk about that. So some of the work in these presentations supported by PCORI, or the Patient-Centered Outcomes Research Institute, through an engagement award in capacity building. So I'm going to go into sickle cell disease, demographics and pathogenesis, and talk about stroke. What are the traditional treatments to prevent it? Then I'll talk about the vasculopathy that occurs in sickle cell disease, and the treatments to prevent that. And in particular, talk about a severe form of vasculopathy, moyamoya disease, and how surgery helps with that. And then I'll close out for completion. Some of the newer treatments that have been used to prevent stroke, and then talk about our work through the PCORI Engagement Award. So sickle cell disease, as many of you may know, is the most prevalent disorder identified by neonatal blood screening. 9% of those with African ancestry carry the trait, and it's about 200 to 365 live births. It's an autosomal recessive mutation in the beta globin gene, where glutamate substitutes is substituted by valine, causing hemoglobin S. So what happens with hemoglobin S is when it's deoxygenated, or when the oxygen molecule is uncoupled from it, the shape changes of hemoglobin, and it causes it to clump up in the red blood cell, causing the membrane of the cell to become rigid, and forms the characteristic sickle shape. In the U.S., Mississippi has the highest incidence of sickle cell trait, and here you can see the top 6. I put Florida in there because that's where I'm from, as number 6. But if you look at the prevalence of disease, actually Florida and New York have the highest prevalences because of their large populations. And here you can see Illinois, which is 2,500 to 4,999 estimated number of individuals with sickle cell disease. So the problem that that causes the strokes is or one of the problems that causes strokes is um, uh, the vasculopathy or blood vessel disease that sickle cell can cause, and that happens several ways. So if the sickle cell abnormal sickle cell lyses or breaks apart, the abnormal hemoglobin is released, and it can scavenge nitrous oxide, and nitrous oxide is a chemical in the blood vessel that causes them blood vessels to dilate. So if you lose that, then you can cause that can cause constriction of the vessel. Um, Also, as the abnormal cells travel through the really small vessels, the capillaries, they can get stuck because they're less deformable, and cause occlusion that way. Also, they can adhere to the walls of the blood vessel and sort of invite the immune response, and or incite an immune response, causing occlusion that way as well. So there's a lot of um, processes that occur that result in what we call vasculopathy or disease of the blood vessel. Um, and the problem with that is sickle cell can cause stroke. Now, vasculopathy is not the only cause of stroke in sickle cell, but it's a major one. In the first year of life, it's estimated that there's an 11% chance of stroke to occur. And you can see in this curve here, the solid line is the chance of an ischemic stroke or infarctive stroke to occur, and most of it occurs before the age of 20, and then there's a second peak later in the 40s, but not as high as in childhood. There is a risk of hemorrhagic stroke that occurs as well, but the peak of that is in young adulthood. And so the stroke that occurs is what we call a clinical stroke, where people can have symptoms, but there are other types of strokes that occur that are smaller, in deep portions of the brain, and about more than a third of sickle cell patients can get that by the age of 14. So that happens more commonly. The good thing is there's a treatment to prevent that stroke. In 1998, the results of the STOP trial were published, where children with elevated transcranial Doppler velocities, or the speed at which the blood flows through the arteries is measured, and if the speed's above 200, the patients are at high risk for stroke. So in those patients, they receive monthly transfusions, and those that receive transfusions where the abnormal hemoglobin percentage is diminished, they had 92% less risk for stroke. So here's the people that were transfused, and these were the ones that were not. So that was one way to prevent stroke. And in 2016, the Twitch trial looked at hydroxyurea as a medication to prevent stroke, and it was shown to be equivalent to transfusion therapy. The issue with both of these trials is they excluded patients who had stroke before, and they also excluded patients who had severe vascular disease. Up to about 20% of patients can have vasculopathy, and 12% are severe. So there's a subset of patients that were excluded from these trials, and the problem with that subset of patients is that they are at increased risk for stroke. So This is an angiogram or a study that looks at the arteries in the brain, and you can see here on the lateral injection, this is the carotid artery, and you can see how there's a nice a robust caliber of vessel here, and then here it kind of tapers off inside the brain, and in the peripheral circulation of the brain, you should see a lot more branching arteries here, but you don't. And it's replaced by these small abnormal arteries at the base of the brain that kind of remind you of a puff of smoke. And the Japanese coined the term moya moya, which means puff of smoke. And so these are the changes that you see. So if you see this patient has moya moya vasculopathy, and patients with sickle cell disease can get moya moya, and when they have it, the recurrence of stroke or TIAs is twice as high in those with moya moya versus those without. And patients who were shown to have progressive worsening of their arteries in their brain also got new infarcts or strokes. So these are the ones with progressive vasculopathy here. And the cost for the care of stroke is pretty costly, up to about $20 million per year. In the neurosurgery world, there are other types of diseases that cause moya moya, and there's also a form of moya moya that is not due to any particular disease. And that's if it's primary moya moya or moya moya disease. There's a lot of research in our literature where if you augment the flow to the brain, that decreases the risk of stroke. And that can be done by directly plugging in an artery here, a donor artery, into a recipient here, which is the middle cerebral artery. And, you can see the brain underneath it. And that direct plug-in can augment the flow of blood to the brain. There's another technique where you can take the same artery, but you don't cut it, and you harvest the tissues surrounding it, and you lay that on top of the brain after opening up some of the layers of the brain. And what happens is the brain is very hungry for blood flow, and the tissues that you place, or the graft that you place over the brain, sprouts new blood vessels and supplies blood to the brain that way. So there were several studies that tried to look at the results of that in patients with sickle cell disease, but most of them were smaller single institution studies. So our group decided to put together a multi-center study, which was retrospective, though, looking at the effects of revascularization surgery. So we call it the Stroke and Sickle Cell Revascularization Surgery Study, or a scissor study, where we had kids, so patients 18-year-old or less, with sickle cell disease, and they had the moya moya changes. And we looked at patients who, we looked at whatever treatment these patients received, and some of them got medical treatment alone with chronic transfusions or hydroxyurea, and others got surgery on top of the medical therapy. And we looked at their strokes and TIAs and complications. So 15 centers participated, and the centers had to have a active sickle cell program offering neurosurgical treatment in addition to the medical treatment. So here's a list of centers that participated, and you can see how the distribution is kind of similar to that incidence of, or sort of the prevalence of sickle cell disease map that I showed earlier. And so all the patients in the study had moya moya syndrome. All of them were receiving hydroxyurea or transfusion. And we had 140 patients, and 95% of those surgeries were indirect anastomoses. And we found that there were no differences in the patient's age at diagnosis, 5 to 6 years. No difference in when they got transfusions or hydroxyurea, or the age that they were diagnosed with moya moya, which is a little bit later, 9 to 10 years, or the percentage of transfusions or hydroxyurea or length of treatment they were receiving. When we looked at the patients that received surgery, they were a bit older, 11 years versus 6 years. And more patients were on antiplatelet therapy or aspirin to prevent stroke, 75% versus 54%. They had worse baseline modified Rankin scale scores, so worse functional scores at the baseline, and they had more stroke or TIAs prior to treatment. So patients who had surgery patients selected for surgery had worse ischemic disease, which kind of makes sense in the group. You don't offer surgery in somebody who's not having strokes, for example. What did the study show? And basically, the patients that received surgery had decreased odds of CVE, meaning stroke or TIA occurrence, about 3.7 times less. So here's the folks that received surgery, and this is a conservative group here. When the surgical patients were compared to themselves, that showed an even greater effect. So they had lower odds of CVE occurrence post-op compared to the pre-op period, and that was 4.5 times less. And they also had reduced odds of developing ischemia. We did not find any mortalities due to the procedure, and the adverse events were relatively minor. One needed surgery to help with wound healing. The other needed help to drain a hematoma in the brain, and the seizures the strokes we already talked about. So we published this in March of 23 in Pediatric Blood and Cancer. So then we looked at why we tried to figure out what are the indications for patients to get the surgery, which is not something that we were able to discern in the previous study that we showed. And what's the literature that's out there? So for the 2020 guidelines for sickle cell disease, evaluation for surgery suggested if patients have moya-moya syndrome and a history of stroke or TIA. In patients with sickle cell disease and moya-moya, surgery is only for prevention of secondary stroke or primary stroke in patients with TIA. So that's what's out there in the literature. So we decided to look at this a bit closer. What we did was we surveyed the surgeons that were part of the scissors study, and presented to them a bunch of different patient scenarios, and asked them, would you offer surgery to this patient or not? And the different scenarios included how they presented with their ischemia, if they had a stroke with symptoms or no symptoms, if they had a TIA or no, if they had no ischemia at all, if they had moya-moya changes or not, how bad was the narrowing of their arteries, moderate or severe, and did the narrowing of the arteries match the area that was showing lack of blood flow. The IV sign is a radiographic finding on the MRI that denotes slower flow to the brain. And then sometimes patients got perfusion studies where the flow to the brain is actually measured, and they were asked whether they would agree if they would recommend surgery or strongly disagree, and kind of 3 points in between. And this is a busy slide just showing you the different combinations of responses that occurred. Basically the summary is this. In all ischemic presentations, surgery is offered if the narrowing is moderate or severe in the artery, as long as the narrowing matches the area that has slow or lack of blood flow. If they had moya changes, you could offer surgery even in those with moderate stenosis. And if they had no moya changes, they had to have pretty severe stenosis. Now, so these are like the opinions of this group of surgeons. This has not been tested in real life, for example, what the results are, but this is the best information that's out there on indications for surgery. If the situation was equivocal, then the addition of a perfusion study would help in decision making. I won't go into all of those combinations, but note that if there's no history of ischemia, um, uh, um, uh, uh, and no moya changes, surgery was not offered. If they had moya changes, then depending on the degree of stenosis, then they would get offered surgery. So here it is again, sort of in summary. But the importance is moya changes plus stenosis together that match the area of decreased perfusion, resulted in surgical recommendation. So for completeness sake, I'll talk about the other alternative treatments that are not surgical that have been used for stroke prevention. Stem cell transplant in sickle cell disease has been around for a while, and Dr. Su knows a lot more about this than I do. But basically, it's a transplantation of normal stem cells, blood stem cells from a donor to the bone marrow of a sickle cell patient, following the suppression of their bone marrow chemotherapy. So basically, they get a infusion of normal stem cells that then produce the normal hemoglobin, and that when successful is curative. Patients can get problems with their immune system, either having hypoactive or hyperactive immune system. There are actually no randomized trials that compare sickle cells to stem cell transplants to medical management. That's just probably not ethical. The indications for stem cell transplant includes serious complications of sickle cell disease like stroke. There are some studies out there that look at stroke and vasculopathy outcomes after sickle cell disease, and most reported stable infarcts on MRIs, and the vascular disease was actually improved in some, but few had strokes after sickle cell transplant, and the risk factor for that was moderate to severe vascular disease, which you can see here. There's some suggestion that for the patient with severe blood vessel disease, they're still at risk for stroke. And just the last treatment for that, gene therapy. I won't go into all of the details, but basically through molecular techniques, they can modify the DNA either through a vector to deliver a different kind of hemoglobin, or editing the gene um, uh, uh, um, causes a break in the DNA and reactivates formation of a different hemoglobin. These are very new and high, they have a high upfront cost. Um, uh, and the studies that look at their outcomes look at vaso-occlusive crises, but nothing on stroke. So there's needs to be more research on them. Okay, so in the last few minutes, what's next? Um, um, uh, we formed a research network through the Patient-Centered Outcomes Research Institute, an engagement award, and the network we formed is to guide research to prevent pediatric stroke in sickle cell through surgery and other means. And it's the first time that we have clinicians, patients, parents, and advocates all together to help guide research. So we're not actually doing research; we're helping set the stage to do research, and we're doing that by doing things to help find the right questions for the research and the right outcomes. So we have a group of neurosurgeons, hematologists, and neurologists that form the core group in the advisory board. We're excited because we have a neurosurgeon from South Africa, and we have a neurologist, a stroke neurologist from Nigeria, as well as the researchers from the U.S. But the other thing that's exciting here is we have parents and patients that are part of our advisory board, and we have broad representation from different organizations in hematology, neurology, and neurosurgery. Our current project now is we're building 3 different surveys targeted at different groups, so hematologists, neurologists, neurosurgeons, as well as parents and patients. And the topics that we're looking at are for the clinicians is what's their clinical practice like? What drugs do they use? What are their protocols? And what scenarios would they be wanting to get or wanting to participate in a research trial? And for patients and parents, what are barriers to care, barriers to research, outcomes that are important to them, and what are their attitudes towards research? So the survey is released in late October, and hopefully we'll get these out to different constituents. And if you do get an invitation to participate in the survey, please do. So take-home messages: patients with sickle cell disease are at risk for getting stroke. Hydroxyurea and blood transfusions prevent stroke in most cases. However, patients can develop narrowing of their brain arteries in sickle cell disease, of which Moyamoya syndrome is the most severe form. And these patients are at high risk for stroke. The traditional treatments are not as effective at preventing stroke, and stem cell transplants can be used to prevent stroke. Surgery to restore blood flow to the brain has also been used to prevent stroke, and research is being conducted about surgery that you can help shape. So again, thank you for inviting me. Thank you to my co-investigators and the folks in my research team. And if there's time for questions, I would be happy to answer.
Thank you so much, Dr. Aldana. Thank you for the great presentation. Very informative. I think Dr. Su may have a question.
Thank you very much. I think that give a sense of how many kids would get the bypass surgery in each place. Why we need to have such a big network?
Right. So so sickle cell disease is classified as a rare disease, believe it or not, in the U.S. And we looked at the numbers to get to a size of sample where you would have a study that would have valid findings. you need about at least in our calculations about maybe 180 patients per arm, and only children. So that's a lot of children. Just kind of doing the math, there's not enough actually kids in the U.S. That would be able to fit into a study of maybe 4 or 5 years long. So you have to look kind of worldwide to get a study going.
Great, thank you.
There was a question in the chat. Can Moya Moya affect cognitive abilities? From Dennis. The answer is yes. It really depends on the area of ischemia of the brain. So especially the frontal lobe and the temporal lobes, which are squarely in the middle cerebral artery distribution. So the answer is yes. It just depends on the area of the brain that's affected.
We do have some in the Q&A panel. One says, for someone who has developed several antibodies, what will be a likely approach?
I probably leave that to Dr. Su. However, if there is a history of stroke and the changes in the blood vessels that I described, surgery may be an option to prevent stroke, but only for stroke prevention, not for the other complications of sickle cell disease.
Yeah, I agree. And just to chime in a little bit, so having antibodies against red blood cells would make the transfusions a little bit more difficult. And so if you picture a risk-benefit balance, the risks for continuing with transfusion get a little bit higher the more antibodies there are. And so that would tip things more toward exploring other possibilities, such as surgery or transplant or gene therapy.
We have one more last question. As a stem cell recipient, does the awareness for stroke be in high demand? And I feel like the person might be asking, is that something that could be a concern as well after stem cell transplant?
Can you do the neurovascular surgery
sorry.
after transplant? Is that one of the questions?
Yeah, is that the question, Beverly? Sorry.
I think the question might be strokes. Like, is the concern for stroke after stem cell surgery? Having a stem cell surgery, like
I think the concern is much less because that they're effectively cured of sickle cell disease, and it depends if they do have narrowing of the blood vessels. If it's very severe, that might not get better with a transplant, but there's not enough data to support that. It depends. Would be my answer. If they have blood vessel narrowing, then they need to be monitored. But if they don't, then it's probably not an issue.
Well, thank you so much, Dr. Aldana. Thank you very much. We really appreciate it. We were supposed to have a break after this, but we will go straight into our session 2. And I will let my co-host, Dennis McCollum, take over the mic.
Okay, thank you, everybody.
Good morning, Chicago, and welcome to the summit for 2025. I am Dennis McCollum, a patient advocate and board member at SCDI. I'd like to introduce Dr. David Tofovich, assistant professor of clinical medicine at the University of Illinois, Chicago, and he will be speaking on pulmonary hypertension. And you can take it away, Dr. Tofovich.
All right, thanks so much for having me. Can everybody hear me okay, just before you begin? I'm assuming by the lack of noise, everybody can hear me great. I'd just like to share a screen or get capabilities to share a screen.
We hear you well.
Oh, can you hear me better now?
Yes, we hear you really well.
Perfect.
Thank you.
Can I just share screen? Here
Yes,
we go.
please.
And is it full screen for everyone?
Yes, it is.
Great. So I'm going to talk about pulmonary hypertension and sickle cell disease. I've got more slides than I think anybody wants to handle, but I think we can get it done in about 20 minutes and leave some time for questions. I talk fast, so by any means, raise a hand or throw anything in the chat while I'm talking. I don't mind answering questions as we go along. I don't have anything to disclose. Objectives, we're going to identify changes in pulmonary and cardiac function that occur in adults, particularly with sickle cell disease. I'm an adult cardiologist. To understand the pathophysiology that drives pulmonary and cardiac alterations in sickle cell disease. We're going to review some recent updates in the literature, and then we're going to review and understand the screening and treatment recommendations. So this is a primarily clinical focused talk. I think we know most of what's on this first page is, sickle cell disease is obviously an inherited blood disorder. Really, the genotype to phenotype kind of discussions where, are you homozygous, heterozygous? What is the associated gene with it or changes into the genes is very interesting and pertinent to this talk. In general, pulmonary hypertension risk gets worse as you go from a milder genotype associated phenotype to a more severe associated phenotype. So SS plus, S beta 0 thalassemias, highest risk of having pulmonary hypertension. We know that it's interesting that, it is still classified as a rare disease in the US, which I also think is absurd because quite a few people have sickle cell disease and many more are heterozygous and at a risk for sickle cell disease in their offspring. We know that 300 to 400,000 annual births within the United States will be born now with sickle cell disease, and we expect a 30% increase in the global sickle cell disease population by 2050. We expect more than that in the United States. There's a lot on the news, and everybody likes to talk about gene therapy recently, as well as bone marrow transplantation as curative options in sickle cell disease, but for many, this still remains prohibitive. If we look at life expectancy in individuals with sickle cell disease, we see a pretty significant rise beginning just in the mid-1970s, and I hope everybody can see my mouse pointer, all the way up to really the common day because of many changes in treatment therapy. Now, when we compare that to age and risk adjusted other Americans, we still see that there's this pretty significant, almost 2 to 2.5 decade age gap in average life expectancy in between those with sickle cell disease and others. Good news, 98% of individuals with sickle cell disease now live into adulthood. With that, though, we're identifying some unique changes and challenges in what is happening in the disease and how we're treating it. So most typical, what we consider typical sickle cell disease comorbid conditions are age dependent. And these includes things like stroke, pulmonary hypertension, which I'll get into, diastolic heart failure, which is going to be another focus of this talk, but many others. And interestingly, kind of building off of our last one, 24% of individuals with sickle cell disease will have a clinically overt stroke, for example, by the age of 45. We see that as individuals with sickle cell disease age, renovascular disease, so kidney issues, rise as a proportion of disease within the group. Newer literature now shows that, and this is one of my areas of focus, is that when sickle cell disease individuals transition to adult care, they tend to receive less SCD-specific care while having more sickle cell disease related complications and an increased risk for mortality. So in our modern day, and this is actually older data all the way from back to 2013, but it still matches up with what we're seeing in 2025. What is causing individuals with sickle cell disease to die, especially at a younger age? And when we look at claims-based data, we see that the bulk of causes of death can be related to the cardiac and vascular system, and respiratory or the lungs. Things such as congestive heart failure, hypertensive disease, pneumonias, pulmonary embolism, pulmonary hypertension. when this was, I believe, at NIH, when they conducted a single center cohort study between those who were deceased in the group and those who are not, they saw that those who were deceased had much higher rates of pulmonary hypertension, congestive heart failure, myocardial infarction, not the classic heart attacks that we think of, which we'll go into a little bit later, and arrhythmias as well. When you look at, again, going back now to the death data, pulmonary hypertension carries a high mortality risk in individuals with sickle cell disease. Really want to highlight that at the beginning of this lecture. I think many of us know, but for those who are unfamiliar, pulmonary hypertension we define by as a mean pulmonary arterial pressure at rest of greater than 20 millimeters of mercury. It's critical to note that this is a much more stringent, and the bar for diagnosing somebody with sickle cell disease has gotten, with pulmonary hypertension, has gotten lower. So it used to be that we would consider 25 millimeters of mercury as significant. We now consider 20. We screen with non-invasive transthoracic echocardiography. We typically confirm with what's called a right heart catheterization by going into the lungs directly and measuring pulmonary artery pressures. We further subdivide them using 3 different systems altogether. One is the underlying pathophysiology and etiology. Why is sickle cell? Why is pulmonary hypertension happening here? We look at invasively and non-invasively the hemodynamic profile. What changes is pulmonary hypertension causing in the person? And then how do they respond to specific therapies? We assess the disease severity based on, number 1, symptom burden, like in many other diseases. 2, the patient's individual exertion capacity, how much work or how much effort can they do before they tire out. We look at hemodynamics, so what are the pressures in the heart and in the lungs? We look at the heart function itself. Is it normal? Is it deteriorating because of pulmonary hypertension? And again, we also assess it based on how does it respond to the therapies that we have to offer. Now, the World Health Organization, the World Symposium on Pulmonary Hypertension, classify pulmonary hypertension into 5 different groups. So when I was still in medical school, we used to classify pulmonary hypertension and sickle cell disease as group 1, which is pulmonary arterial hypertension. But we now know that it is significantly more complicated, and we classify it as pulmonary group 5, or pulmonary hypertension with unclear or multifactorial mechanisms. Long-winded way of saying there's a whole lot going on. Going back to pulmonary hypertension and where it causes changes. We know that, we tend to break it down really into one class, which is group 1, and then group 2, 3, 4, 5. But the critical thing in sickle cell disease to remember is that it doesn't just affect so just let me explain here this figure. You have the right side of the heart pumps blood into the lungs, pumps blood into the left ventricle. Left ventricle pumps blood back up to the body. When we talk about pre-capillary, before capillary, we mean blood before the lungs. Post-capillary, we mean blood after the lungs. Sickle cell disease, depending on the etiology of, pulmonary hypertension and sickle cell disease, depending on the etiology and exactly what's going on patient to patient, can affect pre-capillary and lead to pre-capillary pulmonary hypertension. Post-capillary changes. It can be due to blood clots in the lungs or a combination of all of the above. When we refer to pre-capillary pulmonary hypertension, we're really referring to pulmonary arterial hypertension, which is a thickening of many different layers of the arteries that come off of the right ventricle and go into the lungs. Okay, that's group 1 pulmonary hypertension. When we talk about hemodynamic pulmonary hypertension, and these definitions now have changed slightly and expanded, it's important to break down where the pulmonary hypertension is happening and then what changes it causes. So we have all pulmonary hypertension defined as a mean pulmonary artery pressure, again, pre-capillary pulmonary artery pressure of greater than 20. Pre-capillary pulmonary hypertension is defined as that only occurs or primarily occurs because there's high pressures in the artery that goes to the lungs. Okay. Isolated post-capillary pulmonary hypertension, also referred to as group 2, happens because of, let me go back, because of high pressures on the left side of the heart that causes post-capillary hypertension, and then that tends to back up fluid and increase pressures before in the lungs and then into the other arteries on the right side. You can have a combination of both, which is called a combined post and pre-capillary pulmonary hypertension. And you can have something called exercise-induced or exercise-associated pulmonary hypertension that only typically causes elevations, or more so causes elevations in pulmonary pressures when an individual is exerting themselves. In order to understand all of these hemodynamics, we have to move beyond just a transthoracic echocardiogram and do a right heart catheterization. For exercise pulmonary hypertension, we do now do this test here. Or in the process of getting this test established, we will typically do a right heart catheterization while exercising the patient. Types of pulmonary hypertension, as I mentioned in sickle cell disease. If we look at pre and post capillary, there's about an even split. Now, if I take all patients with sickle cell disease, particularly adult patients, and we estimate how often does pulmonary hypertension occur, the 3 big trials that we have prospective going back about 10 years now show there's between a 6 and 11% prevalence of pulmonary hypertension in the adult sickle cell disease population. Between those, as I just mentioned, there's about a 1-to-1 pre and post capillary cause of pulmonary hypertension within the group. But in reality, for many patients, it can be a mix of pre-capillary, post-capillary, and if they have a history of blood clots in the lungs, something called CTEP, which is group 4, or pulmonary hypertension caused directly by blood clots in the lungs. Pre-capillary pulmonary hypertension, which is this group 1, and I don't want to get too much into the science and background of it because there's quite a lot going on here, but it's multifactorial. We know that there's direct injury to the arteries themselves. There's reduced nitric oxide availability. What I study is that there's inflammation and something downstream of inflammation called reactive oxygen species that damages the cell wall, myocardiocytes, as well as lung tissue directly. And there can be acute recurrent thrombosis as well as effects of chronic hemolysis. Several systems are associated in heart changes and lung changes within sickle cell disease, as outlined here, but acute chest syndrome, pulmonary hypertension, pulmonary embolism, reactive airway disease, cardiac fibrosis, which is what I study, cardiac arrhythmias, diastolic dysfunction, which is a stiffening of the heart, cardiac hypertrophy, which is a thickening of the heart. There's quite a bit going on here. If we look at the current guidelines in sickle cell disease, they recommend that in asymptomatic children and adults with sickle cell disease, that we should not routinely screen, let me back up. We should not routinely use non-invasive transthoracic echocardiography, or TTE, to identify patients with pulmonary hypertension and sickle cell disease. But it's very low certainty in the evidence. Now, there's a big caveat on these guidelines saying that if you have a history of pulmonary embolism, syncope, connective tissue disorder, leg ulcers, priapism, or abnormal physical exam findings, well, then you should screen in an adult patient with sickle cell disease with a transthoracic echocardiography. It is our center's practice and mine, and our consortium that we also work with, that these guidelines are already a little bit outdated. We think that they're very limited in their scope and their depth. We do not feel that they're stringent enough for additional testing or workup on a case-by-case basis. And honestly, if you're a provider out in the community or even a hematologist, it's a lot. It's a lot per patient to think about. It's a lot. The guidelines are very stringent. There's a lot of exceptions. They're just poor overall is our recommendation. But where I think we agree with the guidelines is that everyone should get a targeted history. Everyone who has sickle cell disease at each visit should get a targeted history for signs and symptoms of cardiac or pulmonary concerns. And then those who are symptomatic, and this is critical, we do recommend early referral to a cardiopulmonary specialist in sickle cell disease. We in the guidelines do recommend a transthoracic echocardiogram, NT-proBNP, and a 6-minute walk test for each symptomatic patient. Often you can, when transitioning to see a cardiopulmonary specialist, expedite the workup for us just by ordering these 3 tests. Now, we actually recommend that all patients, adult patients with sickle cell disease, at least establish care with a hematologist at a sickle cell center. We do a yearly EKG, and some of my work has shown this now, and soon to be published work, a yearly EKG for all adult patients with sickle cell disease. We do recommend at least one transthoracic echo, and this is different than the guidelines, in all adult patients with sickle cell disease in their lifetime, and then discuss in detail those findings with a hematologist. Select asymptomatic patients with sickle cell disease should get then repeated or more frequent testing. And these are any concerning findings on prior echocardiography. This is where discussion with a hematologist or cardiopulmonary specialist helps. Any individuals being considered for curative therapy, pre-sports evaluation, which is it's a good part of my clinic now for sickle cell disease patients, including if they're not homozygotes for SS, definitely should get a transthoracic echocardiogram, and high-risk employment or individuals in high-risk employment with sickle cell disease should have more routine screening with transthoracic echocardiography. For these individuals, depending on them, I would typically say, yeah, so just so Dr. Su is pointing out, you don't for adolescents. Yeah, for adults, by the time that they do, we do routine screening here, at least one in lifetime. Again, this is adult focused. Typical screening for patients with especially with high risk employment or any concerning findings, we'll do every 1 to 3 years. Symptoms to evaluate for, I think, is the classic symptoms that we think of with heart failure and pulmonary hypertension. So dyspnea on exertion, fatigue, or new onset rapid exhaustion, dysopnea or bendopnea. So particularly when you're short of breath, if either laying forward, which is bendopnea, or thopnea when laying down. Overall, new dyspnea, new trouble breathing, new shortness of breath, reductions in exertion capacity. I'm not able to walk as far. I was walking 20 blocks, 6 months ago. Now I'm down to 2. I can't breathe when I lay flat. I can't breathe when I lay over. Those are alarming signs to us. Weight gain, syncope is a very alarming sign to us. Hoarseness is a little bit of a rarer finding and tends to be a later finding. Same with chest pain. Other patients, I mentioned thromboembolism, priapism, or leg ulcers history. Absolutely recommend a screening echocardiogram, previous echocardiogram with elevated TRV velocity, and we'll get to that in a second. Elevated creatinine, high LDH, high ferritin levels, or evidence of a sleep disorder, all reasons why. You can see how this there's a lot here to individualize for each patient. Signs of pulmonary hypertension are varied and relatively non-specific, although some are more specific. And most of the signs of pulmonary hypertension are related to either evidence of cardiac dysfunction or poor oxygen distribution, which can include signs like cyanosis, elevated second heart sound, parasternal right-sided heave, systolic murmur of tricuspid regurgitation, diastolic murmur. But you can also see signs of RV failure in these patients, particularly as they progress. So things like JVD, abdominal distension, hepatomegaly, pulmonary edema, peripheral edema, et cetera, et cetera. So when we screen for pulmonary hypertension in patients with a transthoracic echocardiogram, there's a few things that we look for. But the one I think that most people very quickly recognize, because there's so much literature on it now in sickle cell disease, is the tricuspid regurgitant velocity. This tricuspid valve kind of is a right-sided valve that backs up. That is really a non-invasive marker that we have for the potential of pulmonary hypertension. It lets us estimate roughly. It's a very flawed marker, but it lets us estimate roughly what the pulmonary artery pressures are in an individual. And there's 2 kind of really big cutoff points for us here for the decision tree. One is a tricuspid regurgitant velocity of less than 2.5. That's normal. There we just say continue routine screening in most of the patients. TRV velocity of 2.5 to 2.9. This is where we kind of consider what to do next, whether it's increased screening or escalation of sickle cell disease specific therapies. For this mid group, I always recommend, and guidelines support and literature now supports, a reassessment of PH symptoms, looking and doing a 6-minute walk test in them, and assessing for an NT-proBNP. So if you see a TRV between 2.5 to 2.9 on your screening echo, expanded questionnaire, 6-minute walk test, NT-proBNP, okay, at the very least. TRV velocities of 3.0. I don't immediately jump into right heart catheterization for this point, but there's kind of a TRV of greater than 2.9 or 3.0 and above should trigger, in everybody's head, referral to a cardiopulmonary specialist. Okay. If there's a TRV between 2.5 and 2.9, I still recommend sending many of these patients unless they're completely asymptomatic and there's no other changes on echo. I do recommend sending these patients over to a cardiopulmonary specialist, but especially if they have any signs of PH, a decrease in their 6-minute walk test or an elevated NT-proBNP, they should be referred to us. I do caution about the rest of these recommendations because they are outdated, and we're going to talk about some more specific parameters that we look at when we look at findings in echocardiography. But the one thing to note is that in combination, an NT-proBNP of greater than 160 or a reduction in 6-minute walk test does confer a much higher risk of mortality when combined with an elevated TRV. Okay, this is why we always recommend, if they're in the border zone here, 6-minute walk test and check an NT-proBNP. We mentioned the TRV velocity as a surrogate marker for PA systolic pressures. It's not a great marker, and the reason is that the correlation in very rigorous clinical studies, kind of here on the left, going back over now 10 years, 15 years, was okay. It was moderate correlation. Real world data, some of which we have published, doesn't support that. And there does seem to, in patients with sickle cell disease, TRV does overestimate what the actual pulmonary artery pressures are compared to the general population. Now, there's a lot on this, and this is from the newest guidelines that we have for pulmonary hypertension. But when a transthoracic echocardiography is ordered and done in a patient with sickle cell disease, there's quite a few things that we tend to look at. So we also look at RVs, what's happening in the right ventricle. We look at how flow is going into and out of the right ventricle. We look for signs of RV pressure or volume overload. Oh, sorry. And so some of this may be, depending on where you're practicing, some of these changes may be reported on your transthoracic echocardiogram, your screening, but they may not be directly reported on it. And so if there's any high clinical suspicion, I always recommend early referral to cardiopulmonary specialist. If you see a TRV velocity that's in between the 2.5 and 2.9 range, and you're seeing any other changes, particularly on the right side of the heart, I always recommend early referral, because there are other criteria that we look at, and I don't want to go too deep into it because there's quite a bit that can cause that'll push us for it to be pulmonary hypertension or consider pulmonary hypertension. Therapy for pulmonary hypertension, first line is if they're not on HU, we encourage HU work, especially in high NT BNP or low 6-minute walk test. Second line therapies are additional disease modifying agents in consideration or utilization of chronic exchange transfusions in certain individuals. Now, for pre-capillary pulmonary hypertension, we do have specific therapies that can target it. So that component of group 1 pulmonary hypertension in sickle cell disease, which I'll talk to more about. And then we have options for definitive therapy, such as HSCT, stem cell transplantation, or gene therapy. Honing in on pre-capillary pulmonary hypertension, there's really 3 major groups of medications that we utilize. One, which utilizes the endothelin pro-endothelin 1 pathway. The second group leads to nitrogen oxide handling and availability. And our third is the prostacyclin pathway. Okay. Our first step, if we notice in the lab, and this is, you have your screening echocardiogram, high pressures, we're going to go then immediately into a right heart catheterization. Our first decision tree is, are they reactive, or do they have a positive vasoreactivity test? If that does, that opens us the option of doing calcium channel blockers. Okay. And we will start with calcium channel blockers, and then we'll reassess. If they don't, or in conjunction, depending on what their symptoms are, then we will initiate therapies that can affect one of the aforementioned pathways. Our typical screening after this is that we'll usually see them 1 month and then 3 and 6 months after. And then depending on how they're responding to treatment, we will adjust accordingly. I'm running out of time and I apologize for a lot of slides, but there's quite a bit of cardiovascular change that also occurs. So we have pre-capillary pulmonary hypertension and then post. But it's important to remember that the lungs are not in isolation here. And there's a host of cardiovascular changes that occur in sickle cell disease. So relative hypotension, we mentioned elevated peak pressures, there are changes in heart rate, there's changes in increased cardiac workload and increased fluid retention. There is hyperactivation in many individuals of what's called the renin-angiotensin system, causing much of these changes. And within the heart itself, just like you can get endothelial or vascular damage, blood vessel damage in the pulmonary arteries, you also tend to see it in cardiac tissue in many patients. So you will get cardiac ischemia and reperfusion injury, microvascular dysfunction, and endothelial dysregulation. This is actually a blood clot here in the SA node, which is kind of cool. Many changes there is other changes on how the heart itself can work. Okay, and what happens in many patients with sickle cell disease is that they do have a reduced what's called myocardial reserve, in that the endothelium or the blood vessels within the heart itself cannot react appropriately to increased workload or stress. A subgroup of patients can develop myocardial iron overload due to chronic transfusions and hemolysis. This is a stiffening of the heart because of high iron deposition. It's extremely rare, less than 2%. In patients who show evidence of post-capillary pulmonary hypertension, I do obtain ferritin levels and iron saturation levels to see what the likelihood is, potential likelihood or risk for myocardial iron overload. And then I will assess that with the cardiac MRI. I am very rapidly running out of time. Post-capillary pulmonary hypertension. There is, so I will end this. So there is questions now kind of arising about post-capillary pulmonary hypertension in sickle cell disease, most of which is caused because of some changes in relaxation of the heart. It's still not clear and ongoing what is causing that, whether it's direct fibrosis of the heart or it's reactive and calcium handling. But our therapy for post-capillary hypertension and those with diastolic dysfunction is still limited. We don't know, there's no clearly demonstrated improvement in mortality in patients with post-capillary pulmonary hypertension sickle cell disease. We do encourage for these patients to be started on hydroxyurea if they're not, and potentially other disease-modifying agents. But the evidence for improved survival within this group is still very limited. For chronic transfusion exchanges, I have one patient that we did recommend this on. Otherwise, there's very, very limited data. When I say, there's still questions about, well, do we use cardiac or heart medications in sickle cell disease when they start to develop post-capillary pulmonary hypertension? I do, but it's on a case-by-case basis. The reality is we don't have data. So we will start hydroxyurea if able. If they have evidence of heart failure, clinical evidence, we absolutely start them on a loop diuretic, but we tend to start low and slow, just make sure that we don't induce a vaso-occlusive hysteresis. If there's relative hypertension or proteinuria, we do ACEs and ARBs. Last slide, I promise. We do screen many of these patients for allogeneic hematopoietic stem cell transplant. We do have some data that we co-published with NIH now showing sustained improvements in echocardiographic and hemodynamic parameters almost 2 years out. We do have our sickle cell cardiovascular care clinic here. It's Tuesday p.m., so we're expanding our hours now soon. Please, any patients who are at high risk or you have concerns for, we're more than happy to see them. Yeah, I'll stop there. I'm definitely running long. Happy to take any questions.
Thank you, Dr. Tosovich. We have a couple of questions in the chat. In the Q&A. One is from Terrence Hill. He said, what holistic therapies can be used to help reduce pulmonary hypertension?
That's a great question. Holistic therapy wise, I recommend for most of my sickle cell disease patients, many of the same recommendations that I give to the general public. My oldest sickle cell disease patient now is I believe in her late 80s. And many of, it's not specific to pulmonary hypertension, but overall, it's the same recommendations that I give. As active lifestyle as possible. And that does not have to include, vigorous, strenuous activity, but the more active that we are throughout the day decreases the risk for many cardiovascular complications. pH is a little bit, pulmonary hypertension in sickle cell disease is specific to sickle cell disease. And there's some parameters that without medications, we really can't improve. But, I always recommend the same, diet and exercise recommendations to all of my patients. And it's the general stuff that you'll hear: increased step counts throughout the day, further walking, avoiding of high glycemic index foods, high calorie foods, things like that.
Okay, another question presented by Jennifer Light. In pulmonary hypertension world, does cardiology or pulmonology look more into this? Since many centers don't have a cardiopulmonary specialist, seems like cardiology, correct?
So interestingly, it's both and depends on the site. Big sites have both teams readily available and specialists from both sites and pulmonary hypertension. But you did kind of just nail something on the head there. There's not a lot of pulmonary hypertension or sickle cell cardiopulmonary specialists around or in the world. And part of the goal of symposiums like this is to say, who are the patients, who are the individuals that we need to get into a PH center of excellence, pulmonary hypertension center of excellence, and a sickle cell disease center of excellence, and get them into more tertiary care capable centers. In most community hospitals, the expertise to deal with sickle cell disease pulmonary hypertension does not exist. And so I very much encourage patients who are at risk or who have changes in their echocardiogram to establish with a provider at a sickle cell disease site and a PH sickle cell disease.
Okay, thank you. Another question from Sarah Badova.
Mm-hmm.
Do you recommend screening for pulmonary hypertension in pregnancy?
Sickle cell disease, I do. So I do recommend a screening echocardiogram in patients who have sickle cell disease and are pregnant.
Okay, thank you.
Yeah, that was a great question. I should actually add a slide on that into this presentation. That's a wonderful question.
Okay, thank you. Thank you, Tofovich, Dr. Tofovich. And if any other questions come up, we'll forward them to you. Next, I'd like to introduce Dr. Austin. Let me get this down. Dr. Austin Westovich, instructor of medicine at the University of Chicago, and he will be speaking on acute chest syndrome and respiratory diseases. Thank you, Dr. Westovich.
Can you hear me?
Yes, we can.
And is it the correct, am I sharing the correct version?
You're not sharing anything right now.
Oh, I was sharing something, sorry.
Okay, we're starting to see it. Okay. There we go.
Is it sharing the full screen version?
Yes.
All right, wonderful. Thank you for the opportunity to speak with all of you. I'll be focusing today on acute chest syndrome and sickle cell disease. Just a couple disclosures, a couple honorary from Amgen, and I'm on the editorial board of MD-Calc, which is a online calculator tool. Today, my session objectives are to review acute chest syndrome diagnosis and management, to identify a bedside triage tool for acute chest syndrome severity, and to explore active clinical study for acute chest syndrome. The whole day today is structured around the various complications that exist in sickle cell disease. I may not be the only one who's used this figure today, but we'll be focusing in today specifically on, I guess the formatting shifted it, I'm sorry, on acute chest syndrome. So this is an example of acute chest syndrome. You can see a series of chest x-rays where it goes from dark black lungs all the way to more whited out lungs that eventually heals with time. This process can lead to scarring and long-term complications, including potentially contributing to pulmonary hypertension in the future. That was just discussed, but it's a life-threatening and important sickle cell complication. The definition of acute chest syndrome is that you have radiographic evidence of new consolidation. So that's like some of this whiteout stuff that I just showed here, as well as some new symptom, whether it's fever, low oxygen level, faster breathing rate, retractions, which is sort of like the ways in which you change your breathing with your chest and belly because it's harder to breathe. But having chest pain, cough, or wheezing, or other sounds with the concerning sounds when the doctor is listening to this with a stethoscope. So the radiographic evidence can sometimes be delayed. So sometimes we make a diagnosis clinically based on the symptoms and constellation. But if you have both of these, that's the official diagnosis. So this is an example, again, of X-ray evidence for the first part of the diagnostic criteria. And here you can see the consolidation in the right lower lobe. And of some kind of quick stats about acute chest syndrome, it's the second most common cause of hospital admission in sickle cell disease behind acute painful episodes or VOE, vaso-occlusive events. It's a leading cause of premature death in patients with sickle cell disease. It has about an 80% recurrence rate. We already went over some of the diagnostics of it, but the changes may be delayed and some of the symptoms that patients might be experiencing. Of note, you don't have to have chest pain or fever. It doesn't have to have everything. Sometimes people will talk about pneumonia versus acute chest syndrome. My clinical practice and those of my colleagues at the University of Chicago is not to differentiate between pneumonia and acute chest syndrome because they look the same on chest x-ray and have similar symptoms. So pneumonia may be a bacterial cause of acute chest syndrome, but there are other causes as well of acute chest syndrome. And the onset can often be within 1 to 3 days of when someone's coming in with acute painful episodes. So sometimes patients will come to the emergency department and they'll already have acute chest. Some will develop it during their admission while having an acute painful episode. I already talked a little bit about etiology where one could be an infection, but other potential etiologies of acute chest syndrome include a fat embolism or a piece of fat breaking off and going through the bloodstream and causing a lack of blood flow to part of the lung. A pulmonary embolism, which is basically a blood clot doing the same thing, or PE for short. And then hypoventilation, which means not breathing fully and fully expanding your lungs. For the patients and patient advocates who are on this call, that's partly why we encourage using those incentive spirometers of breathing in fully. So that can be due to pain, due to surgery, or opioids. The lab tests that we recommend for working up include a CBC, complete blood count, inflammatory markers, and hemolysis markers. Some of the other things, ABG, which is a arterial blood gas, is not needed in routine practice, although some people might get them, particularly if you're concerned in the ICU. Pulse oximeter should be part of routine practice. And then whether blood cultures are needed or not, I think is more of a cultural practice, more likely to probably be obtained if someone has had a fever. I talked about how the main imaging workup of this is a chest x-ray, where you should see a consolidation or this sort of white opacity in the chest x-ray involving at least one segment, which is a subsection of a lobe of the lung. And I've already mentioned before that the radiologic signs can lag behind physical signs. The management of acute chest syndrome varies by clinical center. This was presented as part of an ASH education series or American Society of Hematology education series. So this slide is borrowed from one of my colleagues. But I want to note that the biggest questions in management of acute chest syndrome are not whether to give antibiotics or not. Most people give ceftriaxone and azithromycin as antibiotics, but they will treat pain with pain medicine and give supplemental oxygen when needed. But the biggest question is whether you should transfuse, and should that be a simple transfusion or a red cell exchange, or should you not give any transfusion at all? So this is a potential algorithm that could be used of trying to first start with a simple transfusion, which is giving 1 or 2 units of blood, particularly if there's room in your hemoglobin to give that blood. So if a patient's baseline hemoglobin is around 7 and they're coming in at 7 to 8, then maybe people are leaning more towards exchange as opposed to adding volume. But if you've had a drop in hemoglobin, the thought from your baseline, there might be room to give additional units. But if there's bigger concerns about how a patient is doing, particularly requiring going to the ICU, then we're more likely to recommend a red cell exchange, which is about usually, 5 to 7 units of blood exchanged with patient's own blood. to get rid of the sickle cell blood and give normal red blood cells. One of the questions in a prior session was potentially about prevention or different ways we can approach this. And so for this complication, the primary prevention, if we can optimally manage pain, then potentially there's less hypoventilation and some of the other complications that can come afterwards. We also need to be vigilant to try to catch this early. I already talked about the incentive spirometer as a way of potentially preventing things. So, and starting treatment early. Secondary prevention, hydroxyurea, I know has been talked about in other talks, as well as chronic transfusions. And then the potential outcomes, there is a risk of death from acute chest syndrome of about 3%, potentially a neurologic event that's been discussed in prior talks, and poor outcomes if undetected and treated late. So unfortunately, the course of acute chest syndrome can be somewhat unpredictable. So we did some work at the University of Chicago to better understand acute chest syndrome severity and what might help make decisions like, should you use a simple transfusion or red cell exchange? So I'm going to go over some of my own research going forward here. We decided to use something called the SF ratio, which has been used in emergency medicine and intensive care units to better describe the severity of acute chest syndrome in patients with acute chest with sickle cell disease. So the SF ratio is the ratio of the arterial saturation of oxygen to the fraction of inspired oxygen. So what that basically means is you're measuring the pulse oximeter, which is a thing on a finger or sometimes on the ear. And then the fraction of inspired oxygen is just the proportion of oxygen in the air that's being breathed in. So room air is 21%, but if you get a nasal cannula or higher levels of oxygen support, then that fraction of inspired oxygen goes up because you're breathing in a higher proportion of oxygen than you would if you were breathing in the normal air in the room. How that's calculated, the FiO2, if you have a nasal cannula in, which is the most common way of supplementing oxygen, that will be 4 times the flow rate. So if the flow rate is 1, 2, 3, you'd multiply that by 4, add it to the baseline of 21%, and divide that by 100 to make it into a proportion. Or percentage. So this ratio can be calculated through MD-Calc, the disclosure that I shared earlier. I had them add that as one of the calculators if you ever wanted to calculate an SF ratio. And we're working with EPIC team to try to make this just a routine thing available in our flow sheets at University of Chicago. We showed that these SF ratios, and just to orient yourself, a higher SF ratio, aka the closer it is to 480 or so, which is the highest it can be, which is 100 divided by 0.21, the higher it is, the better your oxygenation. So we looked at about 227 admissions related to acute chest syndrome and showed that at ED presentation, or presentation to the emergency room, the SF ratio was at a higher level, but by the time they were patients getting antibiotics or diagnosed with acute chest syndrome, it had fallen, which makes sense. They're receiving some level of supplemental oxygen or their pulse ox had fallen in some capacity. So we focused in on acute chest syndrome diagnosis, which we defined as that chest X-ray or chest CT that showed a new opacity as officially defining the start of acute chest, even though we know that it can lag, but just for research purposes. And we showed that we looked at different cutoffs that we could use to help understand who might be going to the emergency department. So we showed overall that patients with below this threshold of 310, and again, these numbers don't mean as much. I'll explain kind of what they mean on the next slide, clinically. But if we use a threshold of 310, we showed a much larger proportion of patients who were going to the ICU. And by 24 hours or so, almost half of them had transferred to the ICU. And then similarly, we did a sort of stratified analysis, particularly if those who are on home oxygen, we do and use different cutoffs, knowing that if you use home oxygen already, aka nasal cannula at home, then we probably need to use a different threshold for what might consider a transfer to the ICU. To translate these thresholds, the threshold of 310 is 90% on 2 liters of nasal cannula. So for the clinicians in the room, talking to your ICU colleagues about 90% on 2 liters might seem a little bit, I don't know, too cautious. But if you look at the proportion of patients that are going to the ICU, they're likely going to worsen soon. I think this is about the clinical course of acute chest, that again, about kind of getting eyes on people early and trying to prevent complications. The other thresholds that are the threshold of 276 for the home oxygen is equivalent to 91% on 3 liters. And many of our patients on home oxygen are often on 2 liters, maybe 3 liters. So it's not that much of a drop down before they're really at risk of going to the ICU during that admission. This is just a summary of our findings from this paper with the different thresholds and the proportion of patients who had the different interventions. You can see that those who were below our thresholds had much higher rates of red cell exchange compared to those who were above them, and therefore also had lower rates of simple transfusion only. Their hospitalization courses were similar to longer. So while we didn't necessarily see differences in length of stay or mortality, we certainly saw that red cell exchange was used more commonly. So we're proposing that this ratio is a simple bedside triage tool that could be prospectively studied in patients with sickle cell disease, hospitalized with acute chest syndrome, and potentially guide treatment decisions like red cell exchange or ICU transfer. A lot of this work in the SF ratio is to set up a clinical trial that we opened over 2 years ago at the University of Chicago using a new drug, or it's not a new drug overall, but it's a new drug to sickle cell disease called tocilizumab to treat acute chest syndrome. This study came out of evidence from France that there's higher IL-6 or interleukin-6 levels in the sputum, or the stuff that's coughed up by pediatric patients with acute chest syndrome, and IL-6 is the target of tocilizumab. And they've showed also that the severity of acute chest syndrome correlated with having a higher level of IL-6 in your sputum. We already know that tocilizumab has been used off-label for post-transfusion hyperhemolysis and potentially severe acute chest syndrome, so we decided to study it overall in acute chest syndrome. This was also driven by some of the work we did here at U Chicago using low-dose tocilizumab to treat COVID pneumonia. The typical dose of tocilizumab is as high as 800 milligrams. So these were much lower doses of tocilizumab that we're using to treat COVID pneumonia. And they basically showed that after even lower doses of tocilizumab, you were able to see effects in inflammatory markers and fever in COVID pneumonia. And here you can see that some of these are, that basically as the dose is lower, you still are having a significant proportion dropping in their fever level and inflammatory marker, and even those with the lower dose are the ones with having a higher proportion who are having this decline. So we showed here that lower doses are effective. So ultimately then we decided that the tocilizumab dose of 80 milligrams would be used because that's a single vial in our study. So our study is over 2/3 the way through. We've had 49 patients participate, and our goal is 68. So we're hoping to close it out by next year. And we've recruited patients in clinic, those in the hospital, and those in the emergency department, trying to introduce the study as early as possible. And then we randomize them to whether they get tocilizumab 80 milligrams right away, or whether they get it delayed by 48 hours. So everyone's getting the drug who enrolls in the study, but half are getting it right away, and half are getting it delayed by 48 hours. And then we measure a variety of clinical and lab parameters, particularly, apologies for the typo here, but particularly the SF ratio that I just discussed as our primary endpoint. And then we're looking to see rates of readmission and mortality as well. So I want to close there with any questions that people might have. I think I've left about 10 minutes for questions, and I think there's been activity in the chat, so I'm going to come out of the slideshow. And I'll just look at the chat.
Yes, there was a question from Tanya Anderson saying, can you speak to decreasing IV fluids during pain crisis management to minimize the risk of acute chest syndrome development?
Yeah, I think that ASH and or NHLBI have recommendations about maintenance fluids, and because I think there's a concern that VOE or vaso-occlusive events or episodes are potentially precipitated by dehydration. I generally don't recommend a lot of IV fluids because I hear you on the potential for really probably pulmonary edema would be the potential complication there. We've debated in our group a lot that if the chest X-ray shows edema or fluid in the lungs is that acute chest, and we've decided to be more conservative here and consider that as a new opacity, even if it's not a consolidative one that is sort of typically looked at more like pneumonia. But I think that I would say for patients who would like to advocate for themselves, I would highly encourage you to ask the team, why are the fluids here? Are they needed? Particularly if you're drinking enough fluids in the hospital. I think that patients in the hospital, particularly adult patients, are frequently put on fluids that are probably not needed. Dr. Stu, do you want to comment on the risk? Do you
I
have
think
something you want to
vaping,
share?
I think vaping is a bad thing for everybody, and particularly for people with sickle cell. It seems like it would be a risk for acute chest syndrome.
Yeah, I haven't looked at that data specifically, but generally I recommend that people consider when you're inhaling things that it's bringing other things besides the drug into your lungs, and could that cause damage? And I think that the other parts here are that repeated acute chest syndrome is also probably damaging and scarring your lungs. So things that you can do to prevent continued acute chest are probably best for your health. Tanya, for your other question about eligibility, any patient with acute chest syndrome is eligible for our study as long as you're treated at the University of Chicago. Unfortunately, we weren't able to expand it beyond a single site just based on funding. But it doesn't matter whether you're on home oxygen or no home oxygen. Anyone who has their acute chest treated at U Chicago is eligible to be in the study.
Another question is, any resemblance between acute chest syndrome and tuberculosis? What are the possibilities of misdiagnosis as tuberculosis?
So tuberculosis can show up in a variety of ways in the lungs. I think that acute chest syndrome, I would view these syndromes as constellations of symptoms with an unclear cause. So tuberculosis is clearly caused by a specific type of bacteria and which should be treated as such. Acute chest syndrome is some whiteout in the lungs and then fever or cough or things like that, which could be caused by a bacteria, could be caused by a virus, could be caused by inflammation. And that's partly why we're giving this anti-inflammatory drug on top of the antibiotics that are frequently given with acute chest syndrome. So I think that tuberculosis would be unlikely in almost all of the patients that we're doing here. We actually are screening every single patient who consents in the outpatient setting for tuberculosis with our trial per the FDA's recommendation because of the potential increase of reactivation of TB with tocilizumab. But at the dose we're giving it, I'm really not worried about it, and everyone's tuberculosis screening has been negative that we've done. So I think that TB, I would think more about the risk factors of where you're coming from. Or has someone traveled to a TB endemic area recently? Are they potentially have been in the prison system where there's a higher rate of TB? And should there be a kind of higher watch or on your for TB? But I'm curious kind of where that question comes from because I've not heard that one before.
Okay. I got a question. Is scarring, does it go away on the lungs from acute chest or pneumonia? Does it eventually go away, or what are the consequences of having it? Does it contribute to more acute chest or more pneumonia?
I think that acute chest is a little bit understudied, but I would guess I would say that will the scars go away? I mean, if you look at your own skin, do your scars go away? Maybe they fade, you know what I mean? But they're still a little bit there. And I think
Never go
scar
away.
has a lot of scars have a lot of emotional and other sorts of societal connotations too. Generally, damage to the lungs, how much of it is reversible versus irreversible? I think that the showing that acute chest syndrome continues to happen and that patients then develop other chronic lung conditions over time makes me think that some of this is no good for the future. Does that make sense? And the hard part here is, well, what can you really do to avoid it? Like what's really in your control and what's not? I don't know kind of how much gene therapy has or has not been something that people have talked about. Is like, is this something that really could change someone's whole life going forward, or they really reduce this risk? If people like got a transplant early on, would that reduce this risk or not? I don't know. I think this is one of the hardest parts about sickle cell disease is hydroxyurea probably helps a lot of these things in preventing them, but putting all our reliance on adherence to a single drug that has its own complications and own side effects is a lot for patients.
Okay. Thank you, Dr. Westovich.
Thanks for your time.
All right. Beverly, are we taking a break or not?
Let's quickly take a look at the time. We have about 3 minutes. Yes, I would say we can take a break till 12:55. I'm sorry. Am I looking at the right time?
No, I think I'm
No,
up at
we're
12.
not. We're going straight.
We're
We
going
have the
straight?
next-
Okay.
Yes, not yet.
Okay. It is my pleasure to introduce Dr. Saraf Santos. He's an he's a full professor of medicine in the Division of Hematology and Oncology at the University of Illinois, Chicago. He's a professor and director at the Adult Sickle Cell Center, and he will be speaking on renal diseases and sickle cell disease. Thank you, Dr. Saraf.
Thanks, Dennis, for the introduction. And let me pull up my slides here. Oops. Okay. Can you all see them?
Yes. Yes.
Yes.
Great. All right. So I'm going to talk about renal disease for the next 25 minutes or so.
Sorry,
And
not to
he's-
interrupt you.
Did you want that?
It's
Did you want that full screen?
It's not full screen?
No.
not yet.
This is not?
Nope.
How do I do full screen on this? It's full screen on mine.
You might be sharing the screen where it's not full screen.
Let's see. Share screen, entire screen. Okay, can you see it now?
No, still. It's getting bigger, but there you go.
Okay, can you see full screen now?
Yes. Thank you.
Okay, great. All right. I'm going to talk about the kidneys and kidney health in sickle cell disease. So here are my disclosures. So with sickle cell disease, there have been some changes that have helped improve life expectancy. So things like newborn screening, penicillin prophylaxis, implementing hydroxyurea early, and transfusions to prevent stroke risk. And as we've seen people living longer, we've seen that some of the things that may cause some of the problems in people with sickle cell disease have shifted. And now things like heart, lung, and kidney disease represent a large majority of problems that lead to further problems and early death in people with sickle cell disease. And when you look at the kidneys specifically, up to 20% of causes of people passing away is due to kidney failure. If you develop chronic kidney disease, that helps us identify people that are at risk for this. And the problem is that once you go into dialysis, people often have really high problems and burden, with about a quarter passing away within a year of starting dialysis. So what is it about the kidneys that are so important? And the kidney has a lot of functions. We think about the kidneys just kind of making urine, and that is part of the function. So the kidneys do reabsorb water, and it filters out waste through the urine. And the reabsorption of water is really important to help avoid dehydration in sickle cell disease. But the kidneys also tell the body to make red blood cells, and that's through a hormone called EPO. So if the kidneys aren't working well, it doesn't make EPO, and then you can develop worsening anemia. The kidneys also make the active form of vitamin D, which is important for bone health. And in sickle cell disease, if you're low in vitamin D, you actually get more bone pain. The kidneys also regulate the acid and base level in our body, so how acidic the blood is. And this is probably particularly important in sickle cell disease because if the blood is a little bit more acidic, the sickle hemoglobin gives off the oxygen and actually can sickle more. And then finally, the kidneys regulate the blood pressure. And that's through a couple of different ways. It regulates the sodium. It regulates this hormone system that Dr. Tovovich had mentioned earlier, the renin, angiotensin, aldosterone system. And even mild elevations in blood pressure can kind of worsen the blood vessel damage that sickle cell disease causes, leading to things like advanced kidney disease, pulmonary hypertension, and stroke risk. So how do we monitor for the kidney function? And so this picture here, there's millions of these little nephrons, is what they're called, in the kidney. And what happens is blood is going into this nephron, it's going into a web of blood vessels where it filters out the waste, and then the rest of the clean blood goes back into your system. Now, what's going out through that filter is what goes into the urine. And that's the waste that you want to get rid of when you're urinating. So we can monitor how well the kidney is filtering based on blood tests. So that's looking at kind of the blood that's going in and out. And you can look at something called the serum creatinine or the cystatin C. And then in the urine, you want to see if the filter is getting damaged. And the way that we screen for that is for protein or albumin in the urine. So when you come to clinic to see us, some of the things that we'll routinely do, one is a blood test called the serum creatinine. We usually do that about every 3 months just to see what the filtering capacity is. This could be important for things like how we dose hydroxyurea. It has an advantage in that most centers will have it. The disadvantage is that it can often overestimate the filtration rate. We'll talk about that on the next slide. But you do have to take that with a caveat. While cystatin C may be better at being more precise on the true kidney function or filtration rate, but it's not always available. And then for the urine, at least annually, we check the protein in the urine. If it's normal, then we'll keep screening on a yearly basis, especially once you're 10 years or older. There are some caveats, though, depending on the time of the day that you collect it. Other things like if you had a recent crisis or if you have high blood pressure that day may also cause some fluctuation. But it is a good biomarker to predict people that might have more kidney problems down the road. So what are some of the limitations? And so what we often get is a serum creatinine. And this is really important because if you go to an outside hospital where they don't see a lot of people with sickle cell disease, there might be people that have kidney problems that might get missed. And usually the threshold where people say, or the labs will say that you have a high serum creatinine or abnormal kidney function, that's usually somewhere around 1.5. But really nice studies done at Emory by Dr. Gouache had shown that once you get to that point, the kidneys are already pretty badly damaged. Normally you want to be up in this range. So you're actually down to about maybe a quarter of your kidney function by the time you get to that. That's because the kidney may actually leak more creatinine into the urine. It might be associated with muscle mass or just a high output from the high heart rate and because of the anemia. So if you're going to use serum creatinine, you want to make sure you use a formula that doesn't include race. If you use a CKD epi formula without race, that seems to have the least bias compared to a true filtration marker. But the cystatin C seems to be even better, and that shows even less bias. So you want this number to be lower, the difference between the estimated versus the true filtration rate, and it's lower with cystatin C compared to creatinine. So what level should raise the alarm? And this is, again, something important that you all should know, but also the providers should know in the Chicagoland and I think anybody who takes care of sickle cell disease. And Dr. Sargent in Jamaica had shown that you probably have a threshold of around 0.8 and 0.9 in women and men. That probably signifies people that have some kidney problems, especially with the SS type of sickle cell disease. And we've also been able to show that somewhere around that cutoff, around 90 to 100 for the filtration rate, which is often thought to be normal. But in sickle cell disease, it may be people that are having problems with how their kidney is working. They might be at higher risk for high potassium and higher acid levels, which are some of the things that the kidney is important for filtering and monitoring. The other thing that we monitor is that urine albumin ratio. So usually 30 is considered abnormal. So, but if you're at 30 and just a little bit above that 30 to 100, a lot of times our patients will flip-flop between this abnormal level and normalizing. It's once that urine albumin is over 100, that's when we start to see that the kidney is going to more consistently show the protein in the urine. And it's at that level that we're able to identify people that are going to have more kidney problems down the road, like a more rapid decline in their filtration ability. So a couple of the things to remember is if the serum creatinine is over 1, that's a sign that the filtration is abnormal. And if the urine albumin is over 100, that probably means that we need to do something to lower it because these people are at risk for more kidney problems down the road. And more recently, Dr. Xu Zhang from our team integrated the protein in the urine with the filtration rate and developed a heat map. And this was adopted from this kidney disease improving global outcomes definition. And what we found was that if you have people that are in this yellow, mild at-risk zone, orange is moderate risk, and red is high zone, as you get progressively into these higher risk zones, you have a higher risk of progressing, like your kidney function declining in half or going on to dialysis. But this was also able to identify people that were at higher risk of passing away at an early age. And so this is really important to make sure that your providers are screening for the protein in the urine, called the urine albumin, and monitoring your glomerular filtration rate really closely. Because if you start to see abnormalities, you're going to want to see a kidney specialist to try to help protect your kidney. So what are some things that we could do to prevent kidney problems? And so these are some of the lifestyle modifications that we're going to go through. So we'll go through these one by one. So first and foremost is stay well hydrated. So this is a picture of the kidney, and these little strands here are the part of the kidney that helps reabsorb water and prevent dehydration. And this is a picture of what the kidney looks like once you hit adulthood. So a lot of that reabsorption filtration area is lost. So it's really, really important to stay well hydrated. So I like to go by the 8x8 rule, 8 glasses of 8 ounces of water per day. And remember, things like water, juice, milk count. Things that don't count towards hydration, soda does not count, coffee and tea does not count. So you want to make sure that you're getting 8 glasses of water, juice, or milk to stay well hydrated. The other thing that's really important is really tight blood pressure control. And recently, the American Heart Association came up with more stringent guidelines. But Dr. Gorduk and team had actually identified this, a decade before the American Heart Association was identifying this in people with sickle cell disease. So people that had a blood pressure, even in this mild range, over 120 over 70, once that blood pressure kept rising above that, they had a high risk of kidney problems or pulmonary hypertension, what Dr. Tovovich described. And so you want to try to maintain a lower blood pressure if possible. Some ways to do that include a low salt diet. So there's lots of foods that have salt. And a lot of times, it's not the salt that you add to the food. It's salt that the manufacturers have already added to preserve the food. So things like breads, cold cuts, pizza, sandwiches, soup, chicken, sounds pretty much like everything here, tends to have salt. But especially some of these kind of snacks, chips, pretzels, sodas are really loaded with salt. So you want to really try to avoid these. The one thing that you want to monitor for is when you look at the can, look for things like low sodium options. And then when you look at the label, look here at sodium. And you want to count these up. And you want to get less than about probably 3,000 milligrams total. You'll be surprised how quickly that adds up. But you probably want to make sure that you're cautious with the sodium to help protect your kidney, but also to keep the blood pressure down. Another thing that's important for diet is making sure that you have a good balance between fruit and vegetable versus animal protein and processed food. And so fruit and vegetables are going to help increase the basic or non-acidic level. So things like fruits, vegetables, especially fresh ones. You can do frozen. Even canned is okay as long as there's not a lot of sodium. But these kind of foods are going to raise the basic level or lower the acid level. That helps oxygen stay bound to the hemoglobin better, and it helps potentially reduce the sickling. And in people with other forms of kidney disease, eating more fruits and vegetables actually helps protect the kidneys. And this is in contrast to things that are processed. So all of these processed foods have tons of salt and preservatives added in them. Meats have a lot of things that increase the acid level. So these are going to do the opposite effect, where they're going to help drive the oxygen off of the hemoglobin and lead to more sickling. Now, it's sometimes easier to say eat healthy and have low salt and lots of fruits and vegetables. And one of the reasons why this is actually challenging is that you have to have access to this kind of food. And so we had mapped where our patients lived and looked at whether they live close to fresh food sources like grocery stores. What we found was that people that lived in these bright green areas that lived far away from access to healthy foods tended to have these red dots, meaning that their kidney function was declining. And the bigger the red dot, the faster the decline, while people that lived in more darker areas where there was more access to healthy foods tended to have a mix of blue where they had stable kidney function, as well as some of the red dots and smaller red dots. So access to food is a really important thing that we have to work on in terms of advocacy. Now, some of the consequences, and I'm really excited that Dr. Zapatar is going to talk about diabetes and sickle cell disease, but one of the consequences of not having the healthy diet is a risk of diabetes. And it was classically thought that sickle cell disease protects against diabetes, but there's some really nice research from UIC showing that the prevalence of diabetes is very similar to people that are similar in terms of race and age between sickle cell disease and non-sickle cell disease, so around 17, 18%. When we've looked at risk factors for it, things like older age, higher body mass index, higher ferritin, which might reflect increased iron stores, and higher triglycerides, a form of fat in your diet that's staying in your body, that was all associated with a higher risk of diabetes. And importantly, just like how diabetes is a risk factor for kidney disease in the general population, in sickle cell disease, those people that have diabetes have a faster decline in their kidney function. So something important that we have to monitor for, and Dr. Zapatar is going to talk about some of those challenges and ways to do that. Other lifestyle modifications: do not smoke. Do not smoke any tobacco products, because that's going to increase your risk for blood pressure. It causes blood vessel damage, and it offloads oxygen off of the hemoglobin. In the general population, smoking increases the risk of kidney disease about twofold. And then if you have something else on top of it, like high blood pressure or diabetes, that is risk is increased. And recently we showed, and then they also looked at this in a cohort of people with sickle cell disease from France, that if you smoke, it doesn't matter any amount, if you're just consistently smoking, you have a 3 to 7-fold higher risk of kidney disease. One other thing that you have to be cautious with is one of the pain meds called NSAIDs. And so NSAIDs, and I'll talk about what they are in the next button, but what they do is they reduce the blood that's going into this filtering unit. That's because they lowered something called prostaglandins, and prostaglandins are important to keep the vessels open. If you use NSAIDs, they actually go away and the vessels shrink, and so you have less blood going into the kidney filter. Examples of NSAIDs include things like ibuprofen or Advil, naproxen or Aleve, ketorolac or Toradol, indomethacin or Indocin or Soladex. And Toradol, which is something we often use for people that come in for a vaso-occlusive episode, in children, it was associated with a higher risk of kidney injury, especially if you use it for more than one day. So if you come into the hospital, Toradol should really only be given for about 24 hours to just help the acute part of the pain. And then after that, you should be really conservative with it. And even using it consistently on an outpatient basis. This was a study that looked at indomethacin given for 5 days. What they showed was that people with sickle cell disease tended to be very susceptible to the changes in that prostaglandin or inflow of the blood. And people with sickle cell disease had a greater decline in their filtration rate and blood flow to the kidney compared to people without sickle cell disease. So you want to be cautious with using it on a daily basis. Now, how can we help it other than these lifestyle modifications? So one of our tried and true treatments is hydroxyurea. So hydroxyurea helps improve fetal hemoglobin. It has some other benefits that might include things like blood vessel effects, lowering the white blood cell or inflammatory cells. And this was a study looking at the effects of hydroxyurea in children. And there were 2 studies that combined their data, the HUSTLE and the SCRIPT cohort. And what they showed was that if you started earlier, hydroxyurea, you could delay when the albuminuria starts, and it delays the risk of this albuminuria of over 100, that risk factor that we have for when people are at more risk of more kidney problems down the road. In terms of adults, hydroxyurea may also reduce the urine albumin, and this was shown in the cohort from France with sickle cell disease. And they showed that if you were on hydroxyurea, the amount of albuminuria goes significantly lower. Once it's a bit more advanced, you still do get a benefit, but not as much. So it's important to start it early, especially if you start to see signs of this urine albumin going up. Now, another therapy that we use that's kidney specific was adopted from the non-sickle cell disease literature, particularly in diabetes, where the blood flow that's going in gets kind of swollen because on the outflow there's a constriction. So there's a pressure that's building up in that filter. And so what you could give is either these things called ACE inhibitors, like lisinopril. They'll reduce angiotensin production, or angiotensin receptor blockers that block the angiotensin effects. And what that does is it helps relax that blood vessel flowing out, and it helps reduce the pressure within the filtering unit. So these have been investigated in people with sickle cell disease. And so 2 ACE inhibitors that were looked at, these are all small, short-term studies, but captopril and enalapril showed an improvement, and the combination of enalapril with hydroxyurea showed additional benefit. Other medicines like losartan was also shown to have benefit, including both those that have mildly elevated and severely elevated levels of albuminuria. So those are the medicines that we often try to give to help treat the albuminuria. We'll make sure you initiate hydroxyurea, it may help prevent it, but if you aren't on it and you have albuminuria, it's important to be on it. And then those medicines, the ACE inhibitors and ARBs, are used if you continue to have albuminuria. But what happens when your kidney function progresses? So remember that filtration rate, if it's less than about 90 to 100, that's when you want to start worrying about other functions of the kidney that may be affected, especially relevant to sickle cell disease. So if you have an eGFR less than 90, then you have to be really careful about salt restriction. We talked about that, 2 to 3,000. Once you're at this level, you probably want to keep the salt to less than 2,000 milligrams. That's really important because then it won't cause more swelling in the body. There might be some times when you give diuretics. Dr. Tofovich talked about that if you have evidence of pulmonary hypertension. But if you are still getting some swelling or fluid overload, then they might recommend diuretics. But you have to use it really cautiously because of the risk of dehydration. For the bone health, so remember the kidneys are important for making the active form of vitamin D. If you have advanced kidney problems, you want to monitor something called the phosphate level, because if that's getting really high, it's going to actually cause your bone to starve from calcium. And so you want to take a medicine to reduce the phosphate, and then you want to monitor vitamin D levels and then go on a vitamin D replacement if it's low, and it'll help keep the bone a bit more healthy. For blood pressure, be aggressive with blood pressure control, lower the better. But if you have this advanced level of kidney disease, it's going to be a little bit harder to lower the blood pressure completely, but you want to keep that top number less than 130 and the bottom number less than 80. So ACE inhibitors and ARBs, those ones that block the angiotensin, are the first medicine that we give to lower blood pressure. And then second line that we often use are calcium channel blockers like amlodipine. And then you want to monitor the acid base level. And if you're starting to see that the acid level is climbing, you want to put people on bicarbonate, a supplement, which is like an anti-acid, and that'll help normalize the acid level and potentially may help reduce the sickling. And in people in the general kidney disease literature, in the general population, if you go on bicarbonate supplementation, that can also help slow down the progression of the kidney disease. Now, we talked about less than 90. What about if the glomerular filtration rate is even more advanced? Now, what do we do? So, especially if you've already been on the hydroxyurea or you're on these angiotensin medications, you're still having that. This is when we think about chronic exchange transfusion. Dr. Tofovich had mentioned that there are some people with pulmonary hypertension that get it. There's actually an ongoing study that we hope to have data from pretty soon. It's a study where people are randomized that either have pulmonary hypertension or kidney problems, and they're randomized to either continuing standard of care or getting chronic exchange transfusions. And we're going to see if that helps stabilize the kidney function, or at least maybe even reverse some of the kidney problems or pulmonary hypertension problems. So that data, some of the patients are still at the tail end of getting that treatment. And once that data is out, we hope to give the community an update. But there are some case reports showing that in some people, it'll at least help preserve the kidney function based on small, like 1 or 2 case reports. And finally, if the kidney disease continues to progress, that's what we have to think about kidney transplantation. And patients can go onto dialysis. There's 2 types. There's the blood dialysis or something called peritoneal dialysis. And there's some data that peritoneal dialysis may be better tolerated because you don't have as much fluid shifts from being on hemodialysis. But it's really important that once you have advanced kidney failure, that you want to be considered for transplantation. And that's because, and this was a really nice study that came out in 2021 looking at the benefit of kidney transplant. And what they saw was they looked at people that had sickle cell disease and people that did not have sickle cell disease. And they saw that in both cases, you reduce the risk of dying early by almost 50%. And it was similar between people with and without sickle cell disease. So the benefit is there regardless of whether or not you have sickle cell disease. One of the caveats that they found in the study was that people with sickle cell disease were also 30% less likely to be referred for kidney transplant and be considered for it. And this is something that we have to continue to advocate for, including the patients, the providers, and the community, that transplant centers should evaluate people with sickle cell disease because that benefit is there for people with sickle cell disease as well, which is similar to those without sickle cell disease. So in summary, the kidneys are an important part of health in sickle cell disease. Remember to prevent dehydration. EPO causes the red cells to be produced. It's a signal that comes from the kidney. The kidney also regulates vitamin D and bone health. Kidneys also regulate acid levels and blood pressure. So the way that we monitor for it in the clinic, so there's the blood test, it's called serum creatinine, and then cystatin C. So I'll usually measure serum creatinine at least every 3 months, sooner if you're on hydroxyurea because you want to monitor that. And then I'll get a cystatin C once a year just to make sure that I have a bit of a better handle on how the kidneys are filtering. And then the urine test to check at least annually is the urine albumin level. If it's abnormal, then you should be checking it every 3 months. Prevention is critical, so stay well hydrated, try to regulate the blood pressure, have a low acid or like a high fruit and vegetable intake and lower the salt sodium, avoid smoking, and limit your NSAIDs, things like the ibuprofen. You can take it with acute pain, but you don't want to take it for a prolonged period of time. In terms of treatments, hydroxyurea may help protect the kidney. And then if you start to have a lot of protein in the urine, that's when you want to use those angiotensin medicines, the ACE inhibitors or ARBs. And then it's also important to see a kidney specialist early on to help monitor how the kidneys are doing and help with different treatments. So with that, I'd like to acknowledge a lot of our nursing or acute care center staff, our patients and families who are the heart and soul of our center, and then all of our collaborators. Thank you.
Questions?
Yes.
I'm trying to get back on. Oh, I have a question, Dr. Saraf. I just don't know. And does any damage to the kidneys happen to both kidneys, or is it a preference one or the other, or do they both go down into? Because when you hear kidney transplant, is that one kidney or is that both kidneys?
Yeah, that's a great question. And usually what's happening to one kidney is usually happening to the other side as well. And so when you think about like the sickling or other blood vessel damage, it's probably happening on both sides. But you only need one good functional kidney to really do most of the function. So that's why when you have a transplant, they transplant just one kidney to kind of help with the function there.
Okay. Huh.
And if you get the kidney transplant, what we often do is put people on a chronic red blood cell exchange to try to help reduce the sickling and subsequent damage to that transplanted kidney.
Okay. Tanya Anderson asked a question: what alternative to Toradol can be used for inpatient pain management with proteinuria?
Yeah, that's a great question. So usually the dose of Toradol is 30 milligrams. It might be different for children. I apologize, I don't know that. But in adults, you could try a lower dose of 15 milligrams and really closely monitor and make sure that you're hydrating the patient. And then, some of the more classical medicines like the opioids might be better, maybe IV lidocaine or other options. But you can still give the total, especially if the filtration rate, the glomerular filtration rate isn't low. Just maybe a lower dose, like 15 milligrams.
Okay.
I
I've
think
got a
Bridget has her
question.
hand. Yeah, please.
Oh, okay. What about how does drinking alkaline water help you lowering your acid? Is it effective? And these hydrogenate water alkalinizers, are they effective at all?
That's a great question. It's something that I'm hoping we can study one day. Is that or just the sodium pill, like the bicarbonate pill? It's cheap. It might help lower the acid level and help protect the red blood cells. So I think it's a great question. Um, it's it will keep you hydrated, and I think if it helps you, it's worth considering. Yeah.
Okay. But now when you talk about the bicarbonate pill quickly, is that something you can only get us at a certain place? Does your doctor have to order that, or can you get it OTC?
Yeah, usually it's a prescription medicine. And,
Okay.
and usually what they'll do is when we get your blood test, we do measure the acid level. And so if it's kind of dipping down, so around 24 is normal. If it gets below 22, that could be a time to talk to your provider and be like, hey, my acid level is a little bit too high. Is there anything we could do to help improve that?
Okay, great. Thank you.
Yeah, you're welcome.
And another question, how effective is kidney biopsy to determine cause of filter damage?
Yeah, that's another excellent question. And um, it's not done enough, I don't think. The kidney biopsy does carry some risks because they have to put the biopsy into the kidney area, so you have to weigh the risk of the bleeding from it. But I think that in certain situations, if somebody has a lot of proteinuria, especially at a young age, their sickle cell disease is well controlled, and you don't have a good idea why. Sometimes the kidney biopsy could look for other causes that might be contributing to the kidney damage, things like lupus or other kind of conditions that may exacerbate the kidney stress. So I think that's a good reason to be seeing a kidney specialist, especially if there's signs of those kidney labs being abnormal, and then talking with the nephrologist if that might be warranted.
Okay. Thank you, Dr. Saraf. We're going to
My
take a
pleasure.
break and we should be back by 12:55. Is that right, Beverly?
Yes, that is right. We'll take about now a 6 minutes break and be back at 12:55 when we start at that time. Thank you.
Okay, thank you all.
All right, it's 12:55. Good afternoon, everyone, and welcome to session 3 of the summit. My name is Patricia Lasley. I'm a research coordinator at Mount Sinai Hospital in Chicago, and I will be introducing this session's speakers. So our first speaker is Dr. Sally Campbell-Lee. Dr. Campbell-Lee is the Director of Transfusion Medicine at the University of Illinois Hospital and Health Systems. Her research is focused on the use of red blood cell transfusions in sickle cell disease and the immune effects of transfusions. Thank you, Dr. Campbell-Lee. Please begin.
Hi, thank you. Can I share my slides?
Share your screen.
Okay, do you see it?
Yes, it looks perfect. Thank
Okay,
you.
thank you. And thank you for having me this afternoon. So I'm going to review today why transfusions are an important part of the treatment of sickle cell anemia, how the transfusions are given, and a bit of background information that'll help you better understand your blood bank test results, as well as some important things for patients and their caregivers to know about history and record keeping. So, as I'm sure many others have gone over today, the hemoglobin S inside of the red cell, the key issue here is when it polymerizes, it forms into the hardened or less deformable red cells with the sickle shape, which leads to sickling and hemolysis. But there are other impacts of the disease on their blood components, particularly white blood cells, platelets, as well as some things called adhesion molecules that help promote vaso-occlusion in the setting of inflammation, which is another part of sickle cell disease, this background inflammation that leads to the vaso-occlusion. So the benefits of transfusion in sickle cell disease is that it helps to reduce sickling. And this is because the red cells that we use for transfusion are from patients that, or from donors that don't have sickle hemoglobin. So we reduce sickling by infusion of red cells that contain hemoglobin A, and we reduce the proportion of hemoglobin S that's in the circulation. The hemoglobin A red cells also help to improve oxygenation. So this gets more oxygen to the tissues and helps to reduce end organ damage. And it also reduces the viscosity. So the more hemoglobin A that's in the blood and the lower that we are able to keep the hemoglobin S portion, the better the blood flow will be, and it will not be as thickened. So there are many indications for transfusion in sickle cell disease. Acute treatment, our major indication is a patient that's having an acute stroke. However, this is also used quite often for people when they're having acute chest syndrome, as well as aplastic anemia or acute splenic sequestration. So we're very often using this in these settings. However, for preventative treatment, two common indications for chronic transfusion, particularly in the outpatient setting, is to prevent future or additional strokes, particularly in someone who's already had a stroke. There are several studies that show monthly or chronic red cell transfusion on a specific schedule reduce the likelihood of patients having repeat strokes. Another reason for chronic or monthly red cell transfusion is to prevent acute chest syndrome. There are some studies that show this is also beneficial. In addition to all of the other treatments that are available, transfusion has helped improve the quality of life for sickle cell patients and has helped to decrease hospitalizations. So just to highlight a few things about acute stroke, particularly for children with sickle cell disease, they have a very high increase in stroke risk. About 11% of patients will have had a clinically apparent stroke by the age of 20, and almost a quarter by age of 45. Typically in children, it's vaso-occlusion, although you can sometimes see hemorrhagic strokes in adults. So, as I said before, red cell transfusion improves the oxygenation of the blood and helps to reduce sickling by increasing the amount of hemoglobin A and reducing the percentage of hemoglobin S in the circulation. And it also reduces the speed of blood flow in the middle cerebral artery, which is where we primarily measure blood flow that determines the risk of stroke. So the higher the flow rate, the more likely there's going to be a potential stroke. So this is in a number of guidelines, particularly those from the American Society of Hematology, that says that prompt blood transfusion should be given within 2 hours of recognition of stroke symptoms. It is also commonly used to prevent the first stroke, particularly in children who have abnormal transcranial Dopplers. So this is where they're measuring the blood flow in one of the arteries in the brain, the middle cerebral artery. This study, which was a landmark study, showed that there was when children who were randomized to either standard care or to get monthly transfusions to keep the hemoglobin S less than 30. The risk of stroke in the patients who were not getting transfusion was actually quite high. The transfusion group had a 92% lower risk of stroke compared to patients that were getting standard care. And you can see here there was 1 stroke in the transfusion group, but 11 in the standard care. Because of this, this study was actually stopped early. And the recommendation was made for patients with abnormal transcranial Dopplers to be placed on routine transfusion care. Transfusions are also used to prevent stroke recurrence. Again, here the goal is to maintain a hemoglobin S fraction of less than 30%. So we want the amount of circulating hemoglobin S to be less than 30%. One of the things that comes up also with transfusion use is how we're going to provide the transfusions. Are we going to do simple transfusion where we're going to just infuse 1 or 2 units into the patient? Or are we going to do an exchange transfusion where we need to have, special equipment, a nurse, and multiple units of red cells? We're often using anywhere between 3 and 11 or 12 units per exchange, depending on the patient size and their hematocrit. In our, some of our patients are using about 8 units at each exchange. So that comes out, if we see them once a month, that's 96 units a year. So we work very closely with our blood supplier. Blood products are regulated by the Food and Drug Administration, and we rely on volunteer donors to supply red blood cell products. The FDA determines who can donate blood and also determines how it has to be tested. Every unit of blood has to be tested for HIV, hepatitis B, hepatitis C, as well as other viruses, and a parasite that is actually not uncommon in the Midwest called Babesia. So all of the testing has to be negative before the blood comes to the blood bank. And we have to, follow the requirements to properly store the red cells to maintain the safety, purity, and potency of the red cell products. In order to select products appropriately for patients, we need to know the patient's blood type. You may have heard of the ABO blood group. That's the most clinically significant blood group in transfusion medicine. All products have to be ABO compatible. Additionally, and I'm going to talk more about this later, red blood cell products for people with sickle cell anemia should be matched beyond the ABO antigen for additional blood groups. And the red cell should also be from donors who do not have hemoglobin S, who don't have sickle trait at all. So we screen donors to make sure they are trait negative. So the ABO blood group has 4 blood types in it. There's type A, B, AB, and O. We refer to these as antigens. So these are molecules that are on the surface of the red cell membrane. And they're actually carbohydrate antigens in the ABO blood group. So they're made of different sugars, basically. And you inherit a gene that produces a different sugar on the surface of your red cell membrane, depending on what you inherit from your parents. So you can have A antigen on the red cell, B, both, which would give you AB, or you can have neither, which is type O red cells. The interesting thing about the ABO blood group is that even without transfusion, you have naturally occurring antibodies in your plasma against the antigen that you do not express on the red blood cell. So these antibodies are made by your immune system. We think it happens after exposure to bacteria in the environment that have similar carbohydrate or sugar structures on their surface that cause your immune system to make these antibodies. So if you are A, you're going to have anti-B in your plasma. If you're B, you will have anti-A antibody in your plasma. Group O people have both anti-A and anti-B, and then AB people, because they've got both on their red cells, don't have anti-A or anti-B in their plasma. So we have to know this because it determines how we select compatible red cells for the patient. So for example, if someone is B, we don't want to give them anything that has the A antigen on it because you have anti-A in your plasma. So the compatible red cells for this patient would be either from another B person or from someone who is O, because the O red cells don't have either antigen. However, this is very important for people with sickle cell anemia, is that there are other clinically significant blood groups. Most blood transfusions only need to be matched for ABO and the D antigen. And if you know your blood type, you probably know your, say, B pos or O negative or A negative. The pos negative part only refers to the D antigen, which is part of the Rh blood group. However, the Rh blood group actually has over 50 other antigens in it. So there are actually hundreds of other blood groups on the surface of the red blood cell membrane. And not all of them are as significant as the ones I have in the picture here. So there's ABO. H is actually just there because it's a precursor to ABO blood group. There's one called MNS, there's Cal, I mentioned RH already, Diego, Kidd, and Duffy. In particular, Duffy, Kidd, RH, Cal, and MNS are important to know the type for people with sickle cell disease because we have to match the antigens for some of these blood groups beyond the ABO and the D of the RH blood group. And the reason for that is some people can have an immune reaction against foreign blood groups that they're exposed to after either transfusion and sometimes pregnancy. So the more transfusions you have, the greater the risk is of having an immune reaction against a blood group antigen that is foreign to you. So because of this, the patients will need specially matched blood for their transfusions. And a key thing to know is just like a transplant, the best chance of finding a match, particularly if we're using what we refer to as extended antigen matched red cells, is from a donor of your ethnicity. And that's just because, that's the way these are inherited, traits. So to better understand your blood bank test results, the first thing to know is that particularly if you're transfused regularly, the blood sample used for cross-matching has to be collected within 3 days of the transfusion. So we can't use something that's, weeks or months old because we have to physically have that sample in the blood bank. And we have to use that to cross-match the units that we're going to issue for the patient. This is also a reason why we can't use test results from blood banks outside of our hospital. You can't go to, say, Sinai and get a transfusion using a sample that was collected at our blood bank and vice versa, because we have to physically have the sample in the lab. So there's 3 tests that we do. There's to get prepared for transfusion. The doctor will order something called a type and screen. Prior to the first transfusion, the patient also should have had something done called a phenotype. And then to actually prepare the products that have been selected, we're going to do cross-matching. So the type and screen is where we're performing the ABO and the RHD, the plus or minus part, antigen typing on the patient's red cells. And then we want to test their plasma, which is the liquid part of your blood, to see if there's any antibodies against any of those other non-ABO blood groups that can be clinically significant, to let us know whether or not we need to do more matching for the patient. So we take the pre-transfusion specimen, it comes to us as whole blood. We put it in something called a centrifuge, which is going to spin it and separate it out into plasma, white blood cells and platelets, and then the red blood cells. And then we're going to use the reagents. So we'll have a vial of anti-A, a vial of anti-B, and a vial of anti-D. And then we take the patient's red blood cells and react it with these reagents to find out if there's A, B, or D, or none of the above on the patient's red blood cells. We then take the plasma and test it against A and B red cells to test for the anti-A and anti-B in the patient plasma. And then we'll do an antibody screen with more cells that have been extensively typed for these other non-ABO antigens to make sure the patient's plasma does not react against these other blood groups. Once we've done all that, we then select the appropriate products and perform the cross-matching and then issue the red cells for transfusion. So the front type and back type just refer to the antigen typing on the red cells, which is the front type. And then the back type refers to how we, detecting the anti-A and anti-B in the plasma. They both have to match to determine the patient's blood type accurately. So for instance, if I find the A antigen on the red cells, we need to find anti-B in that same patient's plasma. And this just shows, what it looks like in the tube. So you can see the red blood cells clumping together with the anti-A and no clumping with the anti-B. And then on the back type, we see the patient's plasma causes clumping of the test red cells that are B, and then no clumping with the A cells. So this person's A. The antibody screen is where we take the patient's serum and test it against at least two cells that have been two red blood cells that have been extensively typed for multiple blood groups, and we're looking for antibodies to these other blood groups. We often use something called gel testing. So this is a little card that's slightly smaller than the size of a credit card that has these little tiny tubes on them that have like a gelatinous substance in them. And we add the reagent red blood cells in the patient's serum to these little tubes and look for agglutination, which is when the red cells stick together. So here you see this person has a positive antibody screen with cell 1, but with cell 2, they didn't react. So we have to do more investigation and more testing to be able to type the antibody that this patient has. So when we talk about the risk of transfusion, there are a number of transfusion reactions, including allergic reactions, which are very common. Those are caused by itching. The symptoms are itching and rash, and they're often treated with antihistamine. Usually it's a mild reaction. Other symptoms, including fever, darker than usual urine, pain, especially if it's happening at the infusion site. Although sometimes after a transfusion, patients with sickle cell anemia who get transfused and then go on to have a crisis type pain afterwards, that can also be a sign of a impending transfusion reaction. Sweating and anxiety, these symptoms can be seen with several types of reactions. The one we worry about most here would be a hemolytic reaction. And then there are other reactions that can impact your breathing. These are all, lumped together, relatively rare. The one risk that is specific and very significant to people with sickle cell anemia is the formation of antibodies to non-ABO blood group antigens. Scientifically, we refer to this as red blood cell alloimmunization. That means you've had an immune response to foreign red blood cells. So why does this occur in patients after transfusion? Because when we look at overall the likelihood of antibody formation after transfusion, if I take all the patients in the United States that get transfused red blood cells, somewhere between 2 and 5% of all of them will make antibodies. However, in people with sickle cell anemia, there are some series where the antibody formation rate is up to 50 and then some 60%. The reason for this is that there are differences in the frequency of antigen distribution between the donor population, who are mainly Caucasian, and people of African descent. You can see here, for instance, there's a disparate distribution with this antigen. This is called Big C. This is part of the Rh blood group. So about 30% of Caucasian people are negative for Big C, but 60% of people of African descent lack the Big C antigen. So this means that if you are Big C negative and you are exposed to blood from someone that's Big C positive, you can make anti-Big C. And this is one of the most common antibodies we see in people who've been transfused with sickle cell anemia. However, one thing that's important to note is that in particular, the antigens with the largest disparity, for instance, here, if we look at this blood group, Duffy, Those are not the most common antibodies. The most common antibodies are in the Rh blood group and in something called Cal. And so these likely point to other poorly understood immune factors, such as the underlying inflammatory state that lead to antibody formation. So because of this, anyone with sickle cell anemia should have their red blood cell phenotype done prior to transfusion. So this is where we type U not only for the A and B and the D part, but we type for all of these other antigens that can be significant. Usually it's on the order of 14 or 15 other antigens that we're typing for. All people with sickle cell anemia, if they get red cell transfusions, should be at a minimum matched for big C, big E, and Cal at a minimum, because those are the most common antibodies. People who've made antibodies to other blood group antigens have to get red cells that lack that antigen that they've become sensitized to, as well as extended matched red cells for these other blood groups. And so an example is, patient 1 is O-pos, has a negative antibody screen, has no history of antibodies. Their red cells should be O-pos, and they will be matched for the big C, big E, and the Cal on top of that. Patient 2 is A-pos, but has a history of anti-Cal. So their red cells should be A and matched for these other antigens on top of the A matching. So in summary, red cell transfusion is an important part of therapy for people with sickle cell anemia. However, antibody production against foreign blood groups can happen, and we prevent this by prophylactically matching at least for C, E, and Cal, and we match for more antigens if the patient has an antibody. And the last bit that I wanted to leave the group with today is that if you need a transfusion at a hospital that is outside of your regular use, please know that the blood bank at that hospital can call your other regular blood bank to get your full transfusion history. So for instance, if you usually come to UIC, we get phone, the other hospital can call us and we can tell them what your transfusion history is. Unfortunately, we don't share blood histories electronically. But the phone call will do it where we can make sure the other hospital has the information to prevent the patient from getting the wrong type of transfusion. And so that's the end of my presentation. I think I've only left a couple of minutes for questions.
Are there any questions for Dr. Campbell Lee? I don't see any in the chat or the Q&A. I have a very quick question. What
Yes.
if, is it up to the patients to offer this information that they get transfusions at another hospital? What if they don't offer that information? How is it determined?
So we often, and by we, I mean the blood bank. We know particularly people with certain diagnoses are likely to have been transfused somewhere else if we're not familiar with them or have never received a type from them before. When the blood is ordered, the ordering physician tells us this patient has sickle cell anemia. And so if it's someone we've never seen before, we will call the doctor and we'll ask them to ask the patient where they've received treatment before. And even if it's in another state, we will call them to get the history. Doing this, we've averted hemolytic reactions on several occasions because we did not know. The patient had a negative antibody screen, but that does not mean that you don't have a history of prior antibody formation.
Thank you. Are there any other questions for Dr. Campbell?
Yes,
Dennis
I
McCullough.
got a question. Does your blood information type and all that have to be, can it be on an individual pain plan?
It can, I've seen people put that in like their care plan, but even especially if you go to different hospitals and even when you come back to the same hospital, you still have to have another, I can't work with historical blood type information. I have to
And
get,
that's what I was gonna ask. Does it
Right.
change? Would it change?
no, it doesn't change. But if I last saw you, say, 3 months ago, and you get admitted today, I still need a new sample because I have to have that sample that's not older than 3 days old to cross-match any blood for you. If I use a sample that's too old, it may not reflect your current immune status, meaning since the last time you got transfused, you may have made a new antibody that doesn't get picked up by a sample that's too old. There are some studies that show that people can make new antibodies within 4 days of transfusion. So that's why the FDA requires for frequently transfused patients, the sample has to be at least no more than 3 days old. We want something that reflects your current immune status.
Second question, does blood have a shelf life?
Yes. So red blood cells can only be stored for up to 42 days. That's a liquid red blood cell, meaning one that's ready for transfusion. Occasionally, particularly for patients with sickle cell anemia who have many, many antibodies, their red blood cells are frozen so that we can store them longer. Frozen red blood cells are good for 10 years. However, I can't like thaw it in the microwave or anything like that. It has to go through a special process where it gets thawed and washed. We put chemicals in it to keep the red cells fresh while they're frozen. And so it requires extra processing time to use frozen red cells. So
Thank
that's
you.
why we constantly need to collect blood. We really rely on donations from the African American community in particular, because as I said before, those are the donors that are most likely going to be good matches for people with sickle cell anemia who are of African descent. I see a question here about lower the risk of transfusion reactions or alloimmunization. So there's several things we do in the blood bank to prevent this. We want to use, of course, we do a lot of work to make sure the red blood cells are compatible. One of the things the patient can do to help reduce the risk of reactions is make sure that when the transfusion is administered at bedside, the nurse coming to administer it should be checking your wristband and matching the labeling on that red cell unit to you to make sure that that is your blood. That is one thing that the patient can be actively involved in and make sure that they're doing the proper bedside identification. The biggest incompatibility risk is getting the wrong ABO type. If they're, giving, say, a group O patient is accidentally given group A red cells. We use electronic systems at our hospital to prevent that, but we still require the nursing staff to check the paperwork, the labeling on the bag, and the patient's wristband. And they should also be asking you to state your name and date of birth. The patient bedside identification is the key thing that prevents the biggest hemolytic risk.
Can you
Yes.
Last question,
can you
go
name
ahead.
a situation? I'm sorry. Can you name a situation where a patient is, I think, positive for a certain antibody, but they are treated as negative? What circumstance would that happen?
Yeah, so I didn't want to get into that because that's kind of complicated.
Oh, okay.
But there are what we refer to as variant antigens. So in particular with the Rh blood group, there are lots of variations where the patient may type as positive for a particular antigen, but then we treat them as negative because I know that molecularly, and that antigen the patient has, if they have a variant antigen, is a little different than it usually looks. And that some of those patients can make antibodies. And so that's why we will give negative. So for example, there's lots of variants to the D antigen of the Rh blood group. And when we do the phenotyping for people with sickle cell anemia at our hospital, we use molecular methods so that we can get this information. So if it comes back that you have a variant D antigen, I'm gonna tell the blood bank to pretend you're D negative so that I don't expose you to other people's D antigen, and then you end up making anti-D even though you look like you're D positive.
Oh, okay. Thank you.
Yeah.
Thank you so much, Dr. Campbell-Lee. This was fascinating.
You're welcome.
Definitely.
And if there's other questions, I think Dr. Sue, I see him online. People can reach out to me through him, or I don't know if my email was distributed. I'm happy to take other questions. Thank you.
Okay, our next speaker is Dr. Joseph Zappeter. Dr. Zappeter currently serves as a clinical instructor in the Division of Endocrinology, Diabetes, and Metabolism at the University of Illinois at Chicago. His work integrates clinical practice with research and studying metabolic disorders. Dr. Zappeter, are you ready to share your screen?
Yes, I am. Let me bring it up here. All right, can you see my screen?
It's okay, there you go. It's perfect.
All right. All right, well, thank you very much for the introduction and good afternoon, everyone. Today I'm going to talk a little bit about diabetes in sickle cell disease. Now, diabetes, when we think of it in the context of sickle cell disease, historically, we don't really think about diabetes as much. And this is mainly because of the lower prevalence of obesity amongst individuals with sickle cell anemia, but also the hypermetabolic state, which utilizes glucose much more intensely, and therefore blood sugars tend to not be increased as much. However, over the last decade, there's been more and more research that has shown that there seems to be more of a link between hemoglobin S and sickle cell disease and the development and progression of the diabetic state. And so what my plan here today is to go over a little bit of the studies that have linked hemoglobin S to diabetes, and then discuss ways in which we can potentially try to identify diabetes in individuals with sickle cell disease in the clinical setting as we go forward. So I do not have any disclosures or any conflicts of interest to discuss. And so a quick overview of diabetes and sickle cell disease. They're both increasing in prevalence and will continue to do so in the coming decades. So right now, type 2 diabetes affects about 1 in 10 adults in the entire world. And that's a little bit higher in the United States at about 1 to 7 individuals. Now, alarmingly, in the United States, there's about 8.7 million adults that are not diagnosed with diabetes but have the disease. And there's also 97.6 million people who have prediabetes. And as these individuals become diagnosed and progress over to diabetes, it is predicted that in the coming 20 years or so, that diabetes is going to affect about 1 in 5 adults in the United States, which is very alarming to see. Now, paralleling this increase in type 2 diabetes, sickle cell trait, having 1 copy of hemoglobin S, affects about 300 million worldwide, and sickle cell disease affects about 7.7 million worldwide. About 1 in 12 African Americans have the trait, and sickle cell disease affects about 100,000 adults in the United States. And it is also predicted that sickle cell disease will affect 400,000 infants in the coming decades, which is an increase of about 100,000 infants that is predicted at the coming time. But with the advances in technology to improve the lives of those with sickle cell disease, individuals with sickle cell disease are living longer, and consequently, they are becoming much more overweight. And we're starting to see that more nowadays. And this is the target of why diabetes is now becoming more into the forefront when we talk about individuals with sickle cell trait and sickle cell disease. And the concept of developing diabetes in sickle cell disease is seen recently in a study of US adults between 2009 and 2014, in which they compared individuals with sickle cell disease to African Americans from the National Health and Nutrition Examination Survey. And what they found is that from 2009 to 2014, the prevalence of type 2 diabetes showed a modest increase in those with sickle cell disease, up to 16.5%, which was statistically significant. And now the prevalence of diabetes in sickle cell disease individuals is comparable to African Americans who do not have sickle cell disease. So we are seeing a shift upwards in diabetes in this population. However, and this is what's also a little alarming, and that is that individuals with hemoglobin S are currently 85% less likely to be diagnosed with diabetes. This can be for several different reasons, which I will go over as well too, but it is a very large number, and that means that we really need to start understanding how does sickle cell disease interact with diabetes and promote its development so that we can understand how to better identify and diagnose diabetes in these patients when we see them in our clinics. One of the biggest challenges that we have right now is the inaccuracy of hemoglobin A1C. A couple of studies here showed that in individuals with the sickle cell trait showed that these individuals had fasting glucoses that were higher than what would be predicted by a hemoglobin A1C level. Furthermore, individuals with sickle cell trait had a higher 2-hour oral glucose tolerance test glucose value compared to individuals who do not have sickle cell trait, despite both groups having similar hemoglobin A1C levels. And also fructosamine, which is sometimes used as an alternative to hemoglobin A1C, has been found to be greater in individuals with sickle cell trait as compared to what the hemoglobin A1C level is. So hemoglobin A1C is our first go-to in the endocrinology clinic when it comes to diagnosing diabetes, and it has shown to be inaccurate when trying to diagnose someone with diabetes who has sickle cell trait or sickle cell disease. And the main reason for this is that glucose irreversibly binds to hemoglobin, and along the typical 3-month lifespan of a red blood cell, a certain proportion of red blood cells will be coated by sugar. But if there is hemolysis and fragility of the membrane that causes hemolysis of the red blood cell sooner than 3 months, well, then there is less time available for sugar to bind to hemoglobin. And as such, this can artificially lower the hemoglobin A1C in individuals with hemoglobin S, and therefore we could cause us to miss a diagnosis of diabetes. Despite this, it is still important to distinguish a link between sickle cell hemoglobin S and diabetes, because several studies have shown a link between the two. So this one GWAS study that was done was trying to understand why was it that Blacks had a higher hemoglobin A1C compared to non-Hispanic whites in the United States. And so what this group did here was they looked at different genetic markers that would cause erythrocyte disorders as well as hemoglobinopathies to assess for if there is a link between those genetic markers and the hemoglobin A1C. And one of the main findings of the paper was that the sickle cell variant RS334 was associated with significance with a higher A1C in Blacks compared to non-Hispanic whites. So if this is true, how is it that sickle cell variant is linked to the development of diabetes? A few other studies that I do want to point out here, and that is there are 2 more studies that have shown that there's a link between hemoglobin S and the development of diabetes. This first study here in United States military veterans looked at military personnel who have sickle cell trait or just one copy of the hemoglobin S allele. And what they found was that military veterans with sickle cell trait had a higher risk of diabetes and a higher prevalence of type 2 diabetes compared to military veterans, African Americans, who did not have hemoglobin S. Furthermore, in a study in the United Kingdom looking at at individuals in the UK Biobank, it was a similar finding was found in which individuals with sickle cell trait had a higher risk and prevalence of type 2 diabetes compared to those who did not have sickle cell trait. So that's already raising a little bit of a concern that there's some sort of link that we don't understand between having hemoglobin S and developing type 2 diabetes. To also make this even take it a step further, there have been many studies that have looked at what is the risk of having hemoglobin S in developing diabetic complications. So many studies have looked at individuals that have hemoglobin S and diabetes and compared this to individuals who have diabetes but no hemoglobin S. And these studies have found that from the circulatory standpoint, there's an increase in hypertension, arterial wall stiffness, and blood viscosity in those with diabetes and hemoglobin S. From a kidney perspective, as we've heard from Dr. Saraf, there is lower filtration rate, leading to higher microalbuminuria and overall a higher rate of nephropathy, a higher risk of nephropathy in these individuals. And also there has been a finding of an increase in rhabdomyolysis in people with diabetes plus hemoglobin S. From an inflammation standpoint, there's increased fibrinogen, interleukin-1 beta, advanced glycation end products, and hence an overall increase in oxidative stress throughout the body. From a metabolic standpoint, individuals with diabetes plus hemoglobin S have higher triglycerides on average than those who do not have hemoglobin S, as well as increased incidences of hypoglycemia. And from the eye perspective, there's an increase in retinopathy, an increased risk of retinopathy in those with diabetes plus hemoglobin S. And so this also means that the severity of the disease is also more. So with this, it's clear that we need to be able to find ways that we can identify glycemic dysregulation in individuals with hemoglobin S, identify it early, and get it treated as early as we can, something that we are significantly lacking at this current time. So the question, though, also becomes, what is the rationale for how does hemoglobin S affect glycemic regulation? So what is the mechanism? Because that can give us a lot of information into how can we actually handle these patients when we see them in the clinic. And the exact mechanisms are not fully understood at this time, but I will give you the studies that have looked at different mechanisms for how it can develop. So here's a small study that was done in a university hospital in Ibadan, Nigeria, in which they looked at a population of individuals with normal adult human hemoglobin and those with sickle cell disease. All these participants here were healthy and they did not have glycemic dysregulation, meaning that they did not have a clinical diagnosis of prediabetes or diabetes. In individuals with sickle cell disease were in a steady state for a minimum of 3 months. And what was found was in the presence of a lower weight, BMI, and waist circumference, it was found that individuals with sickle cell disease had lower serum insulin levels and a lower HOMA-IR, suggesting increased insulin sensitivity, which potentially goes along with, could be a compensatory mechanism for the lower serum insulin, but same glucose levels. However, interestingly, individuals with sickle cell disease had a lower HOMA beta. And what that means is that they have a lower potential for lower secretory potential from the pancreatic beta cells in secreting insulin. So when you see this, the question becomes, is there lower secretion of insulin leading to the lower serum insulin, but the body was still compensating by increasing insulin sensitivity? A similar conclusion came to a study in Greece, looking at a group of individuals with and without sickle cell anemia, individuals between the ages of 40 and 60. Everyone was healthy without a diagnosis of diabetes. And in this study, there was comparable fasting glucose. Those with sickle cell anemia had lower fasting insulin. And also this time they gave the patients an oral glucose tolerance test, and they found that the glucose excursions at 1 and 2 hours after the glucose load were higher in individuals with sickle cell anemia compared to those who had normal hemoglobin. And the insulin levels during the glucose tolerance test were lower in sickle cell anemia compared to those with normal hemoglobin, suggesting the inability to make sufficient insulin to take care of those higher glucose levels. Once again, suggesting an issue with pancreatic dysfunction. The study also went a little further and took a look at beta cell secretory function and found that the higher iron stores that one has, the lower beta cell secretory function is present. So how could iron affect secretion from the beta cells? Well, there is one, the main pathway here is that in the presence of iron overload, when iron gets into the cells, it goes through the Fenton reaction in which it combines with peroxidase and forms hydroxide radicals that can then lead to lipid peroxidation and overall cell death. And this will occur amongst the beta cells in the pancreas that can lead to a decrease in overall insulin secretion. When you have decreased insulin secretion, you can't take care of blood glucose. And furthermore, you cannot suppress hepatic glucose production, leading to even more glucose being put into the blood. Insulin resistance can also form, which I will discuss on the next slides. This is a general overview of the predicted mechanisms that are still under investigation. I think Dr. Campbell Lee had this picture in her presentation as well too. But in the blood, the formation of free hemoglobin, depletion of nitric oxide can lead to vasoconstriction that reduces blood flow to distant tissues, reducing the amount of glucose that can reach those tissues. But also, this leads to the increase in cytokines and reactive oxygen species within the blood vessels, which can travel to various tissues. And what it can do in the various tissues is that the oxidative stress will lead to the phosphorylation of insulin receptor 1 protein at the serine residues. Now, IRS proteins need to be phosphorylated on tyrosine in order to allow for the insulin signaling cascade to occur. So when they're phosphorylated on serine, you cannot have insulin signaling. And in such a way, this oxidative stress can cause insulin resistance by preventing signaling in different tissues through the insulin signaling cascade. And what I also want to mention next is that some of the work that we've been doing here in the Division of Endocrinology at the University of Illinois at Chicago to try to put into perspective, how is it that glycemic dysregulation develops? At what age does it develop? And what is the course of the disease? We have been using a humanized mouse model of sickle cell disease here, in which we have mice that have human hemoglobin in lieu of mouse hemoglobin with normal human alpha globin chains and either normal or sickle beta globin chains in a way that we can create mice that have normal human hemoglobin, sickle cell trait, and sickle cell disease. And these mice have been shown to recapitulate the histopathologic and hematologic features of human sickle cell disease, which makes them a good model to understand glycemic regulation in the context of sickle cell disease. A few results that I just want to point out with you. We took a look at these 3 groups of mice, and we followed them from ages 8 to 20 weeks of age, both males and females. And what we see here is that the mice with sickle cell disease phenotype have higher random glucose levels as well as fasting glucose levels compared to both wild type and sickle cell trait mice, and it goes for both the males and the females. Taking a look at the insulin levels, we took a look at fasting insulin, and what we found was that fasting insulin levels decline from 8 to 20 weeks of age and become significantly lower at 20 weeks of age compared to earlier time points, suggesting the development of beta cell demise. The C-peptide confirms this at 20 weeks of age too, in which the sickle cell disease mice have lower C-peptide levels both in the males and the females. So there is a level of beta cell dysfunction that's occurring, but it is a little bit interesting that at 8 weeks of age, you have higher blood sugar, but you have comparable insulin levels. It could mean either that there is insulin resistance early, or the beta cells are not functioning, are not producing enough insulin early in order to take care of the blood sugar. We also found typical pathologies in the liver that we see in sickle cell disease. And in the pancreas, we noticed that we can see the acinar tissues and we can see the islets of Langerhans, though we did notice in sickle cell disease that the islets of Langerhans were smaller. So when we saw the pancreatic beta cell, oh, one thing I should also say is that iron was deposited in the liver in sickle cell disease. In the pancreas, it was shown that there was iron deposition in the exocrine pancreas, but by 20 weeks of age, we had not yet seen iron deposition within the islets of Langerhans. We then isolated the islets from these mice, and what we did was we took a look at islet area, beta cell area, and the beta cell mass. And what we found, corresponding to our previous data, that sickle cell disease mice, had a smaller islet area. They had a lower beta cell area and a lower beta cell mass. Interestingly, mice with sickle cell trait had lower islet area, lower beta cell area, and lower beta cell mass, despite having basically glycemic indices that were similar to wild type mice, suggesting that there was a way that in sickle cell trait that there is compensation to ensure for euglycemia at least through 20 weeks of age. So some of the main points I want to quickly go through here is that sickle cell disease mice we found develop early hyperglycemia and develop fasting hypoinsulinemia over time. They exhibit pancreatic islet dysfunction by 20 weeks of age. And sickle cell trait mice exhibit comparable glycemia to wild-type mice, despite smaller pancreatic islets and reduced beta cell mass. And also, I wanted to point out that sickle cell trait mice exhibit early signs of liver dysfunction by 20 weeks of age by having hepatocyte vacuolization, which can develop into further injury if at an older age. But that leaves us with many questions yet to be answered, and that is, what is the underlying mechanism for the early hyperglycemia? Is it that there's insulin resistance that then leads to chronic hyperglycemia and beta cell demise? Or is it that the beta cells are already not functioning and not producing enough insulin to compensate for the high blood sugars? And then what about postprandial glycemic control? And what is the role of liver dysfunction in sickle cell disease that might promote glycemic dysregulation, given that the liver is a main controller of blood sugars? And then in sickle cell trait, are there compensatory mechanisms that maintain normal glycemia, and at what time point are they lost? So there's still a lot of questions that need to be answered, but a lot of things that are starting to develop as more and more of us start to do research on trying to understand how diabetes is linked to hemoglobin S. But in the meantime, while we're in the clinics, we know here that A1C can be falsely low in individuals with sickle cell disease. So it's not the best way for us to monitor someone's blood sugar in the clinic. Other mechanisms, probably our first line that could be used, we can take a look at one's fasting plasma glucose, and we can do that on blood tests when they come to the clinic. It will require the patient to fast for at least 8 hours overnight to be able to get an accurate view of the fasting plasma glucose. We can also test with using an oral glucose tolerance test. And the oral glucose tolerance test is the gold standard by which we can determine whether someone has diabetes or prediabetes or not. But it does recommend that someone fast overnight, and then they have to come in for a visit that's going to last a minimum of 2-3 hours with preparation. So it would take a morning for someone to be able to do this test. And so when it comes to trying to determine what's the best method to utilize to test one's blood sugar, I think it's going to depend on the situation of the patient. From a gold standard standpoint, the oral glucose tolerance test is the first test. But in individuals who have long travel times to get to the clinic, who are not able to stay for the full morning, then we may want to resort to using more fasting plasma glucose levels to assess one's glycemic control. Other mechanisms that can be used, a random plasma glucose, can be utilized if it's difficult for one to fast overnight, or if they have an appointment in the afternoon and they cannot fast from the night prior. And as such, a random plasma glucose on 2 occasions greater than 200 milligrams per deciliter would confirm a diagnosis of diabetes. And fructosamine can be used as an alternative to hemoglobin A1C if we want a quick understanding of blood sugar over the previous 14 days. And then 1,5-anhydroglutatol is kind of a last resort in the event that we cannot find an ideal test to fit an individual. I have only about a few minutes left, so I want to talk a little bit about continuous glucose monitoring. And this is something that we haven't done very much and haven't thought very much about in individuals with sickle cell disease. So continuous glucose monitors can give us a comprehensive assessment of an individual's daily glucose fluctuations for a period of 10 to 15 days. And they have been used to accurately predict glycemic regulation in individuals with hemoglobinopathies, but there are no studies comparing glycemia in individuals with and without hemoglobin S. And we have two main systems that we use for continuous glucose monitoring. We have the Freestyle Libre 3 Plus, and we have the Dexcom G7 system. These, as you can see here, these systems take many readings. And the Libre 3, you see one blood sugar reading every minute and 15 days per sensor. Now, for the studies in individuals with sickle cell disease, I do not recommend the Dexcom G7 because Dexcom G7 readings are falsely elevated in the presence of hydroxyurea and will give us an inaccurate and probably false positives as well with the higher blood sugars seen. But if we use a continuous glucose monitor, some of the things that we can test when it comes to individuals with sickle cell disease is that we can take a look at their average blood sugar overall. We can take a look at a glucose management indicator, which is an estimated hemoglobin A1C based on the glucose collected by the sensor. We also can look at variability. Does someone with sickle cell disease have very high postprandial glycemic runs? This would show in a higher variability. But we can also take a look at time in the target range of 70 to 180, as well as time above range. So it'll give us a much more accurate sense of an individual's glycemic control and can allow us to study the different types of glucose patterns that are present in individuals with sickle cell disease and compare it to those with sickle cell trait and normal adult hemoglobin to have a better understanding of where are the specific differences in those with sickle cell disease and how can we target that when we see them in the clinics. In the interest of time, we're going to go through this, so I'll get to the main points of my talk. So as individuals with sickle cell disease are living longer, becoming more overweight, it is inevitable that the prevalence of chronic diseases like diabetes is going to be increasing. Individuals with hemoglobin S and diabetes face a higher risk for and severity of diabetic complications, making it very critical that we identify and diagnose diabetes accurately and early within this cohort. Hemoglobin A1C cannot be utilized as a reliable indicator of glycemic control due to rapid turnover of red blood cells, leading to a falsely low hemoglobin A1C that would cause us to miss glycemic dysregulation. So using fasting glucose or an oral glucose tolerance test may detect glycemic dysregulation in those with sickle cell disease more accurately, but I think that we need to consider individual preferences and individual situations when we choose which test will be best for each individual. And use of CGM in studies can help us directly compare daily glycemic trends between individuals with and without hemoglobin S. And I think that this could provide us with large insights into how to better diagnose, monitor, and treat glycemic dysregulation in individuals with hemoglobin S. And with that, I thank you for your time and attention. I welcome any questions.
Thank you, Dr. Zappeter. There is a question in the chat from Dr. Sue. Did you say fructosamine has limitations in sickle cell disease or sickle cell trait?
Fructosamine would be more accurate in individuals with sickle cell trait and sickle cell disease, as it does not bind to hemoglobin and can give us an accurate picture of one's glycemic control. The caveat with the fructosamine is that it only checks the glycemic control for the previous 14 days rather than the previous 3 months. Yes, it is better. It's better than a fasting glucose, which gives us a snapshot in the period of time. So it can be used as an alternative. Just we have to keep in mind the limited time range that it can be used in, that it will identify.
Okay, are there any other questions for Dr. Zappeter before we go to our next speaker?
Yes, for incidents of diabetes and sickle cell trait, did you make a distinction between S allele and someone who possibly maybe have C trait?
That is a good question. Now, the studies that I have found have been individuals directly with hemoglobin SS.
Okay. But as
But
for trait,
that is a good, yes.
Okay, thank you. Thank you so much, Dr. Zappeter. That was a great talk. So our next speaker, our final speaker in this session is Dr. Sue. Dr. Louis Sue is a professor of pediatric hematology and oncology and the director of pediatric sickle cell in the Department of Pediatrics at UI Health. He is dedicated to finding cures for sickle cell disease and improving treatment, and into professional education on the topic of sickle cell disease. Thank you, Dr. Sue. Please go ahead.
Thank you. And I'm going to try to share screen. Everybody stretch. We've been on this call for a while. Okay. Let's see, can you see my, whoops. Now you see my email. There we go. Can people see my screen? Spleen and infections?
We can see you. We can also see an extra you.
Okay. Oops. I'm going to get rid of my other one. All right, we'll just go ahead. Here's my disclosures. I do some consulting, some research. I'll talk about FDA approved indications. So the hallmark of sickle cell disease, as everybody knows, is severe acute pain, but spleen problems are very, very common. And we're going to talk about those today in the context of other things that can go wrong in the body that are not about pain, not about anemia. So where is the spleen? It's in the upper left part of the belly, and normally would be hidden completely by the ribs, but sometimes in sickle cell disease, there can be an enlarged spleen that expands below. And so it have this shape that's kind of like a curved, yeah, a curved object, sort of like the continent of Australia. What does the spleen do? It's a double filter, so that on the one hand, it sends the blood past white blood cells that try to remove germs. And on the other, it goes through a very interesting filtration system where the blood cells have to go through narrow, narrow slits. To show what that's like, one thought I had was to talk about getting through a door. And so you could have two levels of security to get through the door. You could have bouncers who check your ID, and you can also have a screener of some sort, that like metal detector. But another would be, this is what a diagram on the left is the microscopic picture of what these narrow slits look like in the spleen. And that reminded me of the window blinds in my office. And those are red blood cell models trying to fit through the Venetian blinds. And you can see that the red blood cells could go through and they would fall through to the other side. But if you have sickle red cells, which are shaped kind of in a curved farming tool shape, the sickle, or like a banana, they might have trouble getting through the Venetian blinds, or they might be able to rotate through and be able to get through and eventually get to the other side. But it might take them a little while. And so that is part of the issue. Every single second with the blood going through the spleen for an individual with sickle cell disease is that some of those red cells are not making it through very well. And so you'd have this situation where in a normal individual, normal red blood cells going from left to right through this narrow slits of the spleen, they all basically make it through with very few exceptions, like 0.1% might not make it through. But for sickle red cells, many would not make it all the way through. And so that's one of the places where the red blood cells get pulled out of the circulation, and then they could just clog the spleen, get stuck further. It could contribute to more anemia. And so those are the things that can happen in the spleen with sickle red blood cells every single second as blood is passing through that organ. And just to give you an idea of crowds trying to pass through narrow places, this is, I think it was a University of Michigan stadium entrance. So here's an enlarged spleen diagram taken from a parent's teaching guide showing that the spleen could be different sizes in this little girl, that it could be small, tucked up completely underneath the ribs, or it could have these different dotted lines showing more and more enlargement, and sometimes way past the belly button, way past the navel, and spreading so far down that in order to feel for the spleen enlargement, you have to start really far down on the belly to detect it. on a CT scan, spleen could look like this, where there's damage to the spleen. So the spleen is in this red box here on a cross-sectional view of the belly. And some of the more normal spleen would be the paler part, and the part with the arrow where it's darker is where the blood flow has failed to this spleen and knocked off like half of it. In somebody with sickle cell disease, it would not have exactly this pattern of infarct. It would be more like scattered little pieces sprinkled throughout instead of one big, huge part getting infarcted. Sometimes people with sickle cell disease might need to have a splenectomy, might need to have spleen surgery. These pictures are lifted without permission from the web. I'm sorry about that. And so this shows how spleen surgery can be done these days using the laparoscopy technique, where they, instead of making a big incision of several inches, they're using these 3 puncture holes. And then they reach in there with these tools shown on the right-hand side, tools that cut, tools that put a bag around the spleen, tools that cut, that move things around, tools that cover and suture and pull the blood vessels together. And they also blenderize the spleen inside that bag so you can pull it out through a little hole. That's shown in the bottom right picture. I'm not a surgeon. This is all just me telling you what kinds of things might happen. But the key thing in sickle cell disease is the spleen stops working in early childhood in most individuals with SS. And this is not working, even though it was not removed by surgery. So it's called functional lack of a spleen, functional asplenia. And because of this, the sickle cell warriors need to have extra protection from the germs that the spleen normally would filter out. Remember, we talked about 2 filtering processes. One is the red cell shape and flexibility, but the other is the white blood cells trying to filter germs out. And these can occur at different ages, where typically it would be at younger ages, but young could be 2 years old, 14 years. So one would be a 2-year-old, 2-year-old preschooler, often with a upper respiratory infection, because that's what 2-year-olds get. They could have sneezing, coughing, some fever, but then also abdominal pain. And so most people with a cold don't always have abdominal pain. And this 2-year-old with sickle cell has all that going on. And that would be a situation where the spleen is actually causing problems. Another could be spleen enlargement in a 14-year-old who is playing football, getting very dehydrated, heavy exertion causing acidosis, and now has abdominal pain, does not have a fever, does not have a cold, but just put himself into this situation because of dehydration, and the red cells got more stiff and they caused the spleen to get big. And then a third case might be somebody like this, a 25-year-old policeman in the Bahamas who has sickle cell disease SC, but was kind of healthy enough, fit enough to be able to try out for the police force and to be in. But one day while patrolling the streets in his policeman uniform on a hot day, fainted, passed out on the sidewalk, and was found to have an enlarged spleen. Blood pressure went down, spleen was found to be very big. This was also spleen causing problems, but not in a toddler, not even a child. This is in a young adult. So these kinds of scenarios could all occur. And so for those who are healthcare providers at different ages, you could still need to be feeling for that spleen and try to think about that. So let's get back to the first case, the 2-year-old with a cold, fever, abdominal pain. What makes this case an emergency? We're just going to move through this very quickly. This is not suitable for evaluation in an urgent care center or an office because this is a child with sickle cell disease who has a fever. And if you tried to treat them in your office or in the urgent care center, that would probably lead you to a malpractice lawsuit. And I would testify against you that this really needs to be in the emergency department. This past week, I had 2 children brought to different urgent care centers who then got shunted from there to the emergency department because appropriately the urgent care center says, we can't handle you. Why can't they handle you? Well, one is because they were detecting that the spleen was enlarged. So remember this 2-year-old girl with the picture of the big spleen. The other is that to evaluate the patient properly, you need to have labs and imaging. And those are not usually part of the things that an office could do or that an urgent care center could do. The kind of imaging that's needed and labs would be CBC, retic, type screen, chest X-ray, probably IV fluids, probably empiric antibiotics. And these are not things that an urgent care center would be able to do. And particularly, the labs need to be stat. They can't be sent now and then get the result back in 24, 36 hours. You need to be able to compare the results now versus what the patient had before. And the kind of things that a child like this could have, shown in this red box, is that the hemoglobin is much lower than their baseline. So more than 2 grams per deciliter below the baseline. And then the platelets often would be low as well. So where the baseline for this child was normal platelets, today with the big spleen and the fever, the platelets are low, 85. And so these together indicate that blood is getting trapped in the spleen. Both the red cells and the platelets are getting stuck in the spleen. The white cells, not so much. The reticulocytes, not so much. And it's not like a ton of destruction of the red cells. The bilirubin is still okay. So once again, not suitable for an acute care center or an office because you need to have those stat blood results. We do treat this situation, this toddler with a splenic sequestration with a blood transfusion, and often we'll give it in smaller batches. Pediatrics, we think about how much blood and how many cc's per kilo we give. And so it'd be 5 cc's per kilo, which is half of the usual blood transfusion, 10 cc per kilo. And the reason for this is that when you give the transfusion, sometimes that spleen will actually respond to it and shrink down and release some of the blood that was trapped in it, squeeze it back into circulation, and give you a sort of like an auto transfusion. So that you put blood in from outside, you're also getting some more blood from the spleen, and all of a sudden your hemoglobin could rise by a lot. It could rise by 4 grams per deciliter because you have both the transfused ones and then the spleen released ones. And that could put you in a hyperviscosity or volume overload type of situation. And by the way, spleens can hurt, as spleens that are enlarged could be tight, and that could cause pain. There could also be sickle cell pain at the same time. So how do you approach pain assessment in a 2-year-old? I'm in pediatrics, and we often use as many modalities as we can, but the most common thing is that we're asking the parent, because the kid may just be unhappy with me because I just ordered her to get stuck with needles. But the parent would be able to tell you a little bit more about how much the belly was hurting, how much it needs pain medicines. So all of those things, and we try to do pain treatment. So when you have spleen problems, this is related to why infections are a specific vulnerability in sickle cell disease. That sickle cell disease is a condition of immunocompromise. And in places where there's not much antibiotics or treatment, the main reason for children with sickle cell disease to die is infections, malaria, and Streptococcus pneumoniae. Here's a diagram of the Streptococcus pneumoniae bacteria. Looks sort of like a snowman stretched out a little bit, or like a peanut. It's an encapsulated bacteria. It has a coating over it that really requires spleen function and antibodies to be good to help to clear that bacteria from your bloodstream. Streptococcus pneumoniae is a very, very common bacteria spread by people. It has the very, very dangerous habit of being able to double in 20 minutes. And so if you remember doing math, raising things to the second power, double, 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 you go rapidly from a few bacteria to billions and trillions. And so Streptococcus pneumonia can go from fever to intensive care unit sick in 6 hours. Kids would pass out in the waiting room of the pediatrician's office while waiting to get seen. And so Streptococcus pneumonia is potentially deadly for people with sickle cell, can cause pneumonia, acute chest syndrome, can cause meningitis, infection of the brain and the spinal cord, leading to deafness, blindness. You can have blood poisoning, basically Streptococcus running around in your bloodstream, and death. And Streptococcus pneumoniae was the leading cause of death in sickle cell disease before the 1980s. Now, I think not many people on this call were practicing medicine before 1980s. And so you may not have seen this or remember it, but it was really, really horrible. And this is the reason that lots of children did not survive with sickle cell disease in the United States. But I'm happy to tell you these days, vaccination can prevent most of these infections. So there are really effective vaccines against Streptococcus pneumoniae. One of them is called Prevnar. It's given for babies, it's given for young children, it can be given for adults also. And this provides you some shield against the pneumococcal infection. Other infections, and even with the vaccination, however, you still need to get checked out for fever, because there are some things that the vaccine does not cover. Covers like 20 strains, but there are other strains that it doesn't include. Another big infection to mention is Salmonella. Here is another picture lifted from the web without permission. Sorry about that. Salmonella, this ugly thing that has flagella streaming off of it, looks like an alien creature, is very commonly encountered in unclean food. So if you have chicken that was not processed properly, or that has sat around at your church picnic all day, and then you took it home at leftovers at 6 p.m. and you forgot to refrigerate it until 9 p.m., that food is not so good. Raw milk, unpasteurized milk, well known to cause salmonella. Pet turtles have salmonella on their surface, and if you're petting them or kissing them, you are acquiring salmonella onto you. Salmonella in an ordinary person can cause diarrhea, sometimes bloody diarrhea, can make you fairly ill, usually doesn't kill you, but it can. But in somebody with sickle cell disease, it can be much more deadly. So it can cause a lot of bacteria in the bloodstream, can cause bone infections. So you can imagine those bacteria growing now in your bone. And then that sets up something that requires surgery to treat and weeks of antibiotics. and salmonella can cause death. So don't be kissing pet turtles. Use good food safety, and instead of having raw milk, have pasteurized milk. Food safety, wash hands, put stuff in the refrigerator. These are ordinary kinds of precautions. And then the stuff about reptiles. So turtles, lizards, snakes. If you're going to have those as a pet, wash your hands really, really well if you have sickle cell disease. And then one more infection to mention quickly is this kind of virus that has a special problem for sickle cell disease. This little kind of virus is called parvovirus B19. Very, very common virus. Most adults have had it, but it can cause a very severe anemia and is particularly a problem for people with hemolytic anemia, such as sickle cell disease, for pregnant women, and for people with immunocompromised, such as HIV and cancer. In sickle cell disease, it causes really profound drops in your blood counts. Can go from somebody whose usual hemoglobin is 8, can go down to hemoglobin 2 or 3, and can cause a very bad acute chest syndrome, can cause multiple other organs to have problems too, including causing stroke, but is particularly also known for bad pain. Parvovirus is just around, and in this cold and flu seasons through Chicago the next 6 months, is going to circulate. And we had a wave of it in this past spring, and there's probably going to be another wave coming through. So if you hear about parvovirus, it's something to stay away from people. Do social distancing, do hand washing. So in wrap up, and I think I'm a little bit on time, spleen function is lost very early in life in sickle cell disease. A big spleen can be acute splenic sequestration and really needs to get checked out. Vulnerability to infection is part of the reason that people with sickle cell disease need to get more care. And much of that vulnerability is related to the spleen and how the spleen is not functioning to clear bacteria, clear viruses from the bloodstream. Fever is an emergency in sickle cell disease, even if you have vaccinations, and it's not appropriate for somebody with sickle cell to seek care for fever in an urgent care center. They will turn you away. If they're not turning you away, they don't know what they're doing. They should have turned you away. I think you could go to an urgent care center if you have a splinter or something like that. Immunizations have greater benefit in sickle cell than in other people. And food safeties in reptiles are more important. Reptile pets precautions are greater risks in sickle cell disease than for other people. That's a picture of the spleen. So I thank you very much for your attention, and heading back to the moderator. Let me see if there's any questions.
Thank you, Dr. Sue. I have a quick question.
Yeah.
What you indicated salmonella can infect the bone. What part of the bone does it infect? The surface or the marrow or?
Oh, the marrow, yeah. So that the salmonella will tend to set up shop in areas of bone marrow that are damaged already by low oxygen. So if there's tissues that have been damaged before, it can grow there almost like a bacterial culture dish. So this, I saw a kid this month who had moved here from Nigeria, and from Ghana, and he had this big, huge scar on the forearm because he had a surgical removal of large part of his bone marrow that was infected with osteomyelitis and weeks of antibiotics. The rest of him was okay, but it was a permanent problem for that arm.
Are there any questions for Dr. Sue?
Yes, I was really entertained about that part about the turtles, not kissing turtles, and it raised a question about safety with potting soils and protecting yourself against salmonella, because now some of these soils are using chicken litter, chicken litter with chicken, what is it, chicken droppings or whatever. Is that a danger? Does that pose a danger?
I think washing hands really well, and probably don't kiss your potting soil.
Well, if you're growing vegetables in that soil, what
Wash them.
is that a bad idea? Oh, no.
Wash them, and cook
Okay.
them.
Thank you.
Yeah, salmonella will wash off. Or
Are
cook.
there any other questions?
I don't see any more.
There's one in the chat.
Where'd it go? In the chat. Okay. Chat.
I don't see anything else.
A question on
Which immunization should people prioritize? So higher priority ones would be pneumococcal. So one brand name is Prevnar. Another is meningococcal. Brand names are Menveo, Menactra. There's a Haemophilus influenza vaccine, HIB, which children have already received, and then influenza. COVID is also recommended, and I, as a card-carrying Illinois pediatrician, endorse my medical society's recommendation for COVID vaccine, unlike the federal government.
All right, thank you so much, Dr. Sue. So I will hand it off to Bridget Reynolds, who was the moderator for the panel session coming up.
Along with Ryan Cooper. We're going to let Ryan Cooper lead off.
Got all about me. Hi, everyone. My name is Ryan Cooper. I am a research coordinator and person living with sickle cell disease, and I work with Dr. Sue and the transition clinic at UI Health. And I am joined today by Bridget Reynolds, and we will both be speaking on the comorbidities patients with sickle cell disease face for the next half hour. And I will turn it over to Bridget to introduce the rest of our panel and herself.
Okay, and I'll introduce myself too. I'm a patient advocate and I work with SCDI as a hemoglobinopathy counselor as well as engagement coordinator. And on our panel, we have Olufosayo Owani, who is a medical social consultant at UIC. Dennis McCullum, who is a patient advocate and linkage coordinator at UIC. Tanya Anderson, who serves as a patient advocate liaison with SCDI and has a son with sickle cell disease. So she's a caregiver. And we have Dr. Bishop Horace Smith, who is the attending physician in hematology and oncology at Lurie Children's Hospital and pastor of Apostolic Faith Church in Chicago, and the author of a book entitled Blood Works. Okay, let's get started. Our first question we want to present to the panel. First of all, there are a lot of challenges that people are facing who have sickle cell and managing multiple health conditions, comorbidities. And as such, it can present a special challenge with, medications, appointments, and pain management. So I want to open this up to our patients. How can you share your experience living with SCD and maybe another condition, a comorbidity? We can pitch that to.
Can I go?
Yes, Dennis, please.
Yeah, can I have sickle cell, SS, and pulmonary hypertension. And what I get confused on is they say, well, all my life I've been drinking fluids. And now with the pulmonary hypertension, they say limit fluids. So I'm trying to balance the two out. And where does the balance come in at?
So why don't I would like maybe Dr. Horse, I'm sorry, Dr. Smith, to kind of speak to that question. And we know that you serve as a pediatrician, but we have patients who, across the line, across, the age from
spectrum.
Thank you. The spectrum, who will be experiencing comorbidities. And as such, there are some challenges that maybe one disease or one comorbidity says to treat it this way, and what is prescribed for a person with sickle cell may require you to do something else. How do you deal with that as a physician? And what do you tell your patients? How do you manage that?
Yeah, Mr. McCollum has a very intriguing question, and I think it just speaks to the fact that, sickle cell disease has and with comorbidities, it has to be approached in a different way. I think you have to have quality expert care. You have to be treated with a center that has all of these specialties, and then person like on this panel, social workers and others who will coordinate care. One of the things that hurts with chronic care disease is that people are not aware of other diseases and other impacts. And so, as you can understand, with sickle cell, we emphasize again to be very well hydrated. On the other hand, if you have severe pulmonary hypertension, you have to limit fluids in some cases. So you have to have a coordinator. You have to have a single person who is aware of those things and is making sure that your care is not being isolated. That those physicians, those different departments, with access to your chart and your clinic visits are aware, because there should be a balance so that all those things are taken into consideration and you get the right kind of direction so you're not confused as a patient and what to do. Yeah, it was intriguing. I've been drinking foods all my life. I hope so. We all have to. But again, I think the coordination of what you're drinking, the coordination of your medications, that again can give you a balance where your quality of life can be good if those physicians and other healthcare professionals are making sure that you have a coordinated care plan. That plan should be in your chart, should be always be available. You should be aware of it as well so that they can coordinate your care.
Okay. And one more addition to this question, and then I'm going to let Ryan handle the next question. If you're the patient and a situation like this happens to you, and you have a specialist who's telling you to do one thing, who are you going to pitch you see a problem here in a conflict? Who do you present that to? Because a specialist is, saying you really need to do this. But as a patient what you've been told throughout your life and what may maybe present a conflict in your treatment plan. Are you going to pitch it to who do you pitch it to? How do you navigate that?
Yeah, Dr. Shu gave us an example of this about having fever in a kid with sickle cell disease and going to an acute care center. You can't do that. You have to go to the proper place that knows you and coordinates your care, because you cannot have comorbidities and live in a medical space of isolation where the left hand's not know what the right hand is doing. There has to be ongoing communication and understanding and updating of your care by that care team. And someone has to be the quarterback to always check and make sure that's happening. Of course, as you point out, the patient has to be their own advocate sometimes and say, wait a minute, I have sickle cell disease and you're telling me not to drink. How does that impact the other? To kind of push these professionals that sometimes are not aware of these other comorbidities. And sometimes, quite frankly, the emphasis here is that they don't always listen. So I think you have to be in a specialized place with coordination of care. You cannot have isolation. If you do that, you're going to get into trouble because, again, as he's pointed out, one impacts the other.
Thank you. Ryan?
Of course. And I could just speak from my experience as like I said, I'm a adult sickle cell patient, and I was diagnosed with general anxiety disorder and ADHD, so attention deficit hyperactivity disorder, in my mid-20s, so about 4 or 5 years ago. So I'm gonna throw this next one to Fasayo, if you're fine with that. So thinking about some of the patients that maybe you have seen or have not seen, what are some gaps that exist in the healthcare system for addressing such comorbidities like what I've just mentioned? for the sickle cell disease population, and how can they be addressed?
Thank you very much, and thank you for having me. Well, there are several significant gaps in the healthcare system when it comes to addressing comorbidity in the sickle cell disease population. The first, as Dr. Smith mentioned, is care coordination, which is a major gap with individuals often with multiple specialties like hematology, cardiology, nephrology, pain management, to name a few. So in this regards, this creates like a fragmented care, like a silo. They can be like overwhelmed, which can be overwhelming to the patient. They may struggle in navigating like the appointments, follow-up, care instructions, and even remembering the details in their pain treatments. And another is like the integrated care model that brings together specialists, as Dr. Smith mentioned, like with the care primary care providers, social workers, and like in a cohesive team. So this ensures like a continuity of care and making the process less fragmented for the patients. So as a social worker, I play like a key role in helping like coordinating and ensuring that the patient's emotional and practical needs are met alongside the medical needs. And another would be the health disparity, which has all been mentioned throughout the summit. Individuals that we serve with sickle cell is like they're disproportionate, like individuals with low income, racial minority background. And a lot that I face is like they lack insurance or they're underinsured. They have limited to high quality care. And they also encounter like racial biases and misunderstanding in the healthcare setting, which also delay diagnosis, poor treatment, as you mentioned, with your late diagnosis with the mental health component. And to address this disparity, we ensure that the patient have access to comprehensive healthcare services, regardless of their socioeconomic statuses. Expanding insurance coverages, improving cultural competencies along with the healthcare professionals, and also like creating like a cultural cohesive like environment as well. And as a social worker, I can help in advocating for the patient, connecting them to like financial assistance programs, guiding them through the healthcare system and ensuring that they receive the care they need. And as you mentioned as well, lack of mental health support that's integrated into the care of the individual with sickle cell and comorbidities is also very significant. Mental health is also important as the physical health as well. So yes, many people with experiencing sickle cell disease also experience like anxiety, depression, stress, and without access to adequate mental health resources, this emotional burdens often are ignored, untreated. It makes it harder for the patient to manage their conditions effectively. And to address this, mental health services should be integrated into the care model for the patient with sickle cell disease, which encompasses like the social workers, psychologists, therapists, and should be a multidisciplinary team providing screening for depression, anxiety, and offering therapy and supporting coping mechanism for chronic pain and for the emotional toll of multiple conditions. So early intervention and consistent support can prevent more severe mental health issues and improve the overall quality of health. And finally, patient education and health literacy is crucial with individuals struggling with like comorbidity and with sickle cell disease, and having the necessary treatments and how to manage their health daily, providing like a proper education can also be a compilation, and it can also like help prevent like missing appointments and preventing with health maintenances. And there's other, but I'm not going to take too much of the ground that we can mention right now, but this is just a few that I can
Fasal, you are amazing as always. You knocked out the next question I was going to schedule to ask you. But real quick before, and I want to pose this to Dr. Smith and you, Fasal, as well. What would you suggest for someone that looks like us, for maybe caregivers? And Ms. Anderson, maybe you can answer this as well. Who look like us and see that maybe a child is in some need of some mental health intervention. What would you tell maybe a parent?
So thanks, Ryan. I'm sorry, I didn't know if I was supposed to jump in right now.
Any one of you guys. I'm just
Jump in.
You guys are the specialists.
Because this is leading into my next question to direct it to you, Tanya. Okay.
So, hi everyone. I am thankful that we are, first of all, having this forum and these conversations. And as a caregiver, I have a 21-year-old son with SS hemoglobin, and I am part of his transition plan right now and soon to graduate. The idea of knowing that what was said about the mental impact on dealing with just having sickle cell disease, and even though he doesn't have a confirmed diagnosis of another comorbidity, he does see multiple specialists. And just the whole process logistically, from getting to the doctor and now that he's doing this on his own using resources that the insurance provides, the mental impact that all of this has on him creates this fear of not wanting to go sometimes because he doesn't know. And for the parent who is dealing with a child or an adult or transition um, patient that are not sure exactly how to handle this, one of my key strategies is, first of all, have a system, something that allows you to keep all of your information together, a notebook, a binder, or even on your phone, some system that you engage with to help you keep information, store information, even if you're just taking snapshots of things like these summits and information about your pain plan, your baseline information of different things, so that that anxiety from not knowing is a little less prevalent because you've now got some information that you can walk in and say, I know my part. And at least I'm not walking in afraid of not knowing what to answer about myself. And that's what I'm noticing about him and some of his friends also that have sickle cell disease. They are more afraid of what they don't know. And so sometimes less willing to speak up or even ask questions because, unfortunately, they feel sometimes they have a stupid question. And I always grew up knowing that the stupid question is the one that's not asked. And so having that understanding of a system that allows you to keep all your information, it's one component of eliminating or minimizing that anxiety that leads to that mental health crisis that you feel like I can't function, I can't think. And then having something that helps you to like a network, a support group that allows you to feel like, okay, this is what I usually go to as a way to calm me. And I know for my son, we use multiple layers of that. We have a stress management technique that he uses on the spot at his doctor's appointments. It's an aromatherapy stick, and it has different scents that we go to University of Chicago. And so the massage therapist there was just really excellent in helping him to connect to this because he didn't know how well it was helping him. So not only does it provide this scent of helping you to calm down, but it then provides this overall calmness that helps you to think better because of the scent that's in it, the essential oil that helps with helping keep better mental clarity, sage, and I believe thyme, and there was peppermint, and I think one of his favorites is eucalyptus. So some of these things are some of the tools, just a few that we use just to help him get through that part. And I'll let someone else jump in about other information, but I wanted to just express how important it is to have a system. And if the system involves physical things, people, and then ways that you can connect to helping you to not be so fearful or not have so much anxiety. I think that it's helpful when you're planning multiple doctor's appointments to know a schedule, having a calendar. And again, keeping that system is so important because as a caregiver, we definitely are leaned on in that beginning phase of transition and even into the big later stages. So having that system is critical for us.
Yeah,
Thank you.
I would
Thank
jump
you.
in here. I've been taking care of children, adolescents with sickle cell for 45 years. Sickle cell is a chronic disease. In medicine, there is no such thing as having a chronic disease and not having mental, emotional impact. People who have pain. Think about this, as you all know, you cannot quantitate pain with a test. So you have to believe the person telling you that information. That alone, when you are a minority, when you may not be known to someone, you're almost using energy to convince someone of something that cannot be measured. That has an impact every encounter you have. So you have to realize, I think that in sickle cell disease, we have to begin to listen to the patients and add some things that maybe in classical medicine we don't listen to. And that is their experience. That is what they've been going through. Again, pain is something that has to be treated oftentimes with narcotics. The stigma of, and people being accused, well, you're seeking narcotics. Well, they're in pain, and there's a difference. Think about this with cancer or something like that. We understand how acute and how difficult pain management is, but with sickle cell, oftentimes, again, you are labeled. So my point is that I don't think there's a such thing as an adolescent or older with sickle cell who does not have mental, emotional fragility because of the immense impact of this disease that cannot be quantitated in a sociological impact with a care system that doesn't look like you. I think that we have to arm these patients with information, and we have to educate healthcare givers that you should not be seeing a patient with sickle cell if you don't first listen to what their plan has been, what their experience has been. It will help in the long run in the overall treatment of these patients. It's an immense problem. We have to admit it. In America, we have a racial problem that is almost endemic, and we don't always understand explicit and implicit racism, but it does exist. Studies have shown that. This is not even controversial in the literature. So if we know that, then we have to, again, change our approach as medical experts to what we need to be aware of with patients overall and with sickle cell in specific care plans that can help them along the way.
Okay, thank you, Dr. Smith. I like to, Ms. Anderson, Tanya alluded to something about the stupid question, and you've spoken on dealing with the pain. What about the pain that you don't see? I mean, most of our pain can't be hidden, but there's a lot of pain that you don't see. And what is our plan for addressing the pain in patients that they don't show you?
I can jump in with that one. I mean,
Thank
as
you.
everyone has clearly stated, just mention a lot of the points that I was going to touch on, which is why the multidisciplinary approach is critical in the combination with a medical health professional, mental health, social services, because psychological support is crucial with chronic illness such as sickle cell disease. And as Ms. Anderson mentioned, how her son uses like techniques of mindfulness, self-care, in terms of processing some of the mental challenges and anguish. And I always also put in the psychological support, whether it be like a support group, both a peer-led or professionally facilitated one. It provides like an opportunity for patients to be able to connect with others to truly understand, what they're going through. Because sometimes they feel that they're isolated, that they're going through this process by themselves, which is not true, but there's no connection. There's not that correlation to connect them to the necessary aid that they need. So they need like a sense of community to reduce the feeling of isolation and validate their own personal experiences. So patient, you find that comfort and they're able to manage those emotional challenges, and they have like resources that can glean from each other. So, and like, I most like I recommend like therapies for my patient that I deal with all the time. And I found like the cognitive behavior therapy, is very crucial in terms of like helping to cope with the negative thoughts patterns, like building resiliency in the face of like the health challenges that's facing. As Ms. Anderson mentioned, like mindfulness practices, relaxation techniques that she mentioned in terms of like the daily management of it. And also like the self-care, which is crucial. The exercise, the nutrition that have been mentioned throughout the whole the summit, hobbies, just to make sure that you are engaging yourself and you don't feel like you're so isolated by yourself. And also we can't forget like the family and the caregivers, because they are a huge part of the whole structure, and their well-being and their maintenance is also important. So I also advocate for like family therapy, providing caregiver education, and which can improve communication, reduce caregiver burnout, because we know caregivers do get burnout. It's overwhelming because most of the time they're dealing with multiple family members and trying to coordinate that and coordinate appointments and everything else. It becomes exhausting, and helping the families understand the challenges that their loved one face. So it's like an encompass, like it's it involved like multiple involvement of all the practitioners.
Right, right.
Thank you.
Yeah, thank you.
Again, you're amazing. Um, I see we are at about time. We have about 5 minutes left. There is a question in the Q&A box from Miss Newman, and she asked, what advice can I give to parents who have a newborn diagnosed with sickle cell disease? Miss Anderson, if you don't mind answering that one, and then I can open it up to the other ones in the chat since you are a mother and you've lived it. So what would you have to, share with the audience?
Okay, absolutely. And so for the newly diagnosed parent, the parent that has a newly diagnosed child with sickle cell SS, I think that one of the helpful things to do is, first of all, to take a breath and to make sure that you understand how you respond is how they receive. And if you're responding to everything in a crisis, and I'm going off of personal example for myself, don't respond to everything in a everything is a crisis. Look at it holistically first. Be willing to listen and ask questions. It's extremely important. Asking questions. You're not going to know a lot of things. Ask about whatever you don't know, whatever you don't understand. Ask about what the lab results mean. Ask about what does this mean for the next step. Asking questions is one of the things that helped me to help myself help my son, because I had now an understanding of, okay, now I understand what this means. So now I could have better conversations. I could plan better for, okay, this is what we anticipate is coming up for the next visit, so that I could be prepared. Look into nutrition at an early age. I strongly, believe that having a really good nutrition plan for a child that's born with sickle cell disease does make a difference. And just having natural ways of helping the child to stay well. And as I always used to tell my son, as you are feeling well, do everything you can, the same way that you would do if you're in pain. You take everything you can to get out of pain. Turn that around and do everything you can to stay well, to hold on to the wellness. So naturally doing things that help you to stay well so that you can avoid having to be so medicated in everything, avoid constantly having chronic, infections, viruses that lead to more medications that also have more effects, and how your body with sickle cell disease metabolizes all of those things affects your organs. And so knowing how to find a way to stay well naturally as much as possible, and then doing things that allow you as a family to just come together and be encouraging that support and that network, because the more that you can stay together and just continue to grow in your network with your family surrounding you, the more support that child will feel loved. And as it was already mentioned, that is so true, that feeling of isolation doesn't become so prominent, because that is a real thing. And I see it in my son, but I also see it from a caregiver side. You also, as a parent, may feel that isolation, being in the hospital, unfortunately, if that's, a path that occurs. You feel disconnected from all of the events and things that are going on around you as an adult, because your focus is on your child. So making sure you have a support group, a network, and something that you can connect to, or someone or people that allow you to feel like I have a support when I feel tired, when I feel I need to be refreshed, and when I feel like I don't know what else to do or say. And that is one of the things that the Sickle Cell Disease Association of Illinois allows us as caregivers to connect with a support group. And I myself, as a parent advocate liaison, I'm always, helping and looking to help those parents that are looking for those resources and connecting, especially when it comes to starting school. And that's another area that I usually am very passionate about helping families with, those accommodations that parents are not sure what to even ask, or when is it needed, and what type of accommodations would they look like. So I'm just thankful that those are things I pray will be helpful for you as well as a parent.
Okay, and I'd like to speak to that very quickly too, as a person living with sickle cell. Um, I have been on the receiving end growing up as a child with sickle cell. And as I got older, I started thinking about what my parents' experience must have been dealing with, all of my different comorbidities and, runs to the ED and things like that. But the main thing I want to give to you is this: faith. When you're going through troubles, don't count that issue as the last straw, the last thing you'll be dealing with, and something that's going to take you under. Because I've seen too many times where I've experienced things that were very scary and harrowing experiences from time to time, and I got through them. And I didn't know I could get through them. I had no clue I would get through them. I had given myself a death sentence, I don't know how many times, and I had no clue. And I'd be in a meeting and we'd be planning things and people would be planning, and I'd be saying to myself, well, if I'm still alive, and here I am. So you have to have faith that you can get through this, and that there are means to deal with the issue, and planning and being prepared and calming yourself so that you can get from one step to the next step. Take one step at a time, deal with one issue at a time, and you'll see that you'll be making progress and then you're going to get through it. So I think that
Yeah.
really you need the takeaway is about faith, having faith.
Amazing,
I think
Bridget.
the other
Oh, go
piece.
ahead, Dr. Smith.
Yeah, I really want to say this, and I agree with Ms. Anderson. Great perspective, and Ms. Reynolds, who's living it. I would say this: be very careful that you get the proper care from the beginning. It has been like night and day, the lifespan, quality of life of patients who were diagnosed 40 years ago and now. With newborn screening, with the right kind of care at a quality center, we should expect kids to live a normal lifespan and have quality of life. But if you miss those things, again, you're going to be in trouble because I've seen it when I've had patients come, like, let's say from Nigeria, other places where the lifespans were certain. They said, I know my kid's going to die at 30. I said, your kid's not going to die at 30. They're going to live to 70 if they get the proper care and get it on time. The whole issue of, you heard Dr. Sue talk about this. Where do you go when you have a fever? I know it's a hassle, but you've got to understand that we made tremendous strides in sickle cell. It's not the same disease, but if you don't avail yourself of these quality centers that will make sure you stay on target. I have patients now who have become physicians and others because they were diagnosed at birth. They followed the care. They are not always in the hospital. You know, there's a way to make sure your quality of life is the best it can be, but you cannot neglect good medical care. I know we think that natural things will solve it. Natural medicines are important to maintain health, but when you have a diagnosis, you must be aggressively treating that diagnosis. If you do that, you won't have the organ failure and the heart disease at 40. You won't have the pulmonary hypertension. You've got to know this, and these things are available. I think what happens with a lot of times in our population, we don't trust the medical institution. We have some reason why we don't, and so we wait till the last minute. That's a bad choice. Get that newborn should be diagnosed at birth, the right treatment throughout, and they have a great chance to live a normal lifespan with good quality of life.
Okay. We are at time. So if anyone has any other questions, please throw them in the chat and hopefully our panelists will be able to answer them for you. I do want to say a quick thank you to everyone who joined us this afternoon for this talk. It's been amazing. I will shout out to Dr. Smith. You probably don't remember me, but you actually were you remember me. You were my pediatric hematologist back at Children's Memorial, probably over 20 years ago.
That's a
Uh,
long time. I remember you and your family.
yes, yes. And my mom and I were kicking and screaming when we had to leave. But again, I want to thank you for all the work that you've done for me and our community. Uh, God bless you. God bless all of our panelists. And I am going to turn it over to Dr. Sue, and he's going to be closing us out this afternoon.
Thank you very much. Thank you for the panel. So I am going to talk like an auctioneer really fast to close this out. This has been a great session. We've had so many different perspectives, and you've heard the whole gamut from bio to psychosocial to societal and coping and everything else. For those who want continuing education credits, please note this information. You have to show your attendance. You should do your evaluation form. Take a picture of this screen if you need to. Next slide. Take another picture of this slide if you need to. This is additional resources that are available online. From American Society of Hematology, there's guidelines. From Centers for Disease Control and Prevention, there's a lot of patient handouts, useful information. National Institutes of Health also has very useful information. There's some videos in there as well. Sickle Cell Disease Association of America, so the national organization, has a number of resources. There's also an upcoming convention in about 3.5 weeks that will be in Chicago area, in Rosemont, Illinois. UI Health, adult and pediatric care. You can take a picture of this. Sickle Cell Disease Association of Illinois will have, and you see contact information in the chat too. There is a walk, jog, bike-a-thon on September 27th. I think I'm going to be either walking or standing, cheering people on. It'll be in a park on the south side, very close to SCDI headquarters. There's also online events for those who can't make it to that particular one. Take a picture of that. The national convention I mentioned that will be coming up October 15th through 18th at the Lowe's Chicago O'Hare Hotel in Rosemont. Sign up there with this website, that link. And this is the rolling credits. We thank the Sickle Cell Center, the Adult and Pediatric UI Health Comprehensive Sickle Cell Center, Dr. Santosh Saraf. You heard from, I'm from the pediatric part. We have a full span of adult sickle cell providers. This is more than some places, 2 or 3 whole states do not have this many adult sickle cell docs. And then we have partners with Sinai Chicago, with Lawndale Christian Health Center, with University of Illinois Peoria. And our community advisory board has worked really, really hard on this. The planning, did you know, it stretched back about 9 months with practically weekly meetings. So we thank very much the community advisory board. And we thank you all for your participation. See you next year. Don't forget to sign up for the, do the attendance and do the evaluation if you want continuing education. Thank you all very much. Are we on time? Close.
Thank you, everyone. Thank you, Dr. Sue.